Morning. I'm Mike Palacci. I think a couple of you know me. Most of you probably don't. I'm an emergency doc here at Summa. I work with Dr. Johnson and Dr. Gallo. I'm also the medical director for the virtual care sim lab and do a lot of education and stuff with the residency program. Um, this is I'm pretty excited about this morning. This is giving you the opportunity to kind of see what it's like inside a courtroom. Now, keep in mind we're going to do all this inside of about 3 hours, where typically a case like this would last several days, couple weeks potentially. So, this is really compressed, but at least give you the idea of what it's like to be in this situation. Should, heaven forbid, you ever end up in that situation. So, I want to start and thank our attorneys and our expert witnesses, our defendants, for kind of for volunteering your time, and especially to the experts and the defendants for putting themselves out there a little bit. It's not necessarily going to be the most comfortable day, but I think it was going to be very beneficial for everybody. So I'm going to do a brief introduction. There we go. And we'll start just talking a little bit about what is malpractice. So in order for there to be malpractice, there's three elements that are required. Okay, there has to be a duty to treat on the part of the person being accused. And really, as paramedics, whenever you're called out to the scene, there is a duty. You have a duty as part of your job to provide evaluation and treatment for that patient that you're being called to. So the duty is, pretty much universal. The second thing that has to be present is a breach of the standard of care. And that term is thrown around a lot, standard of care. So I just wanted to make sure everyone has a good understanding of what that really means. Standard of care is defined as what a reasonable practitioner, a reasonable person with similar training would do in a similar situation. It's really not what we should be shooting for in our practice. We should really be shooting for excellence in care or best practices, right? But for the purposes of malpractice, what has to be determined is, did this practitioner, did this defendant meet the standard of care? For the reasonable practitioner with similar training would do in a similar situation. A breach of the standard of care can happen really one of two ways. And the legal terms for these are malfeasance or nonfeasance. Malfeasance is the commission of an act that should not have been committed. Whether it's giving a treatment that was contraindicated, performing a procedure that shouldn't have been performed, something along those lines. Nonfeasance is kind of the other side of that coin, where you did not do something that should have been done, did not give a treatment that was indicated, did not take an action that was prudent. Okay, so breach of the standard of care through either malfeasance or nonfeasance. And then the third element, so duty, a breach of the standard of care, and the third element that has to be met, that has to be present, is proximate cause. So was the malfeasance or nonfeasance, was the breach of the standard of care the proximate cause of plaintiff's injury? So let's just, the example I tend to use is like more of a physician example, but I think it should make sense. If I'm a family doctor and I fail to perform what is the standard screening for colon cancer on my patient, I don't recommend a colonoscopy at age 45. And at age 50, that patient is diagnosed with stage 4 colon cancer. I committed nonfeasance. I breached the standard of care. That is a standard of care. Now, if that patient walks out of my office when I told him that he has stage 4 colon cancer, and on the way back to his car, gets hit by a car and dies in the street, I can't be sued for malpractice, because although I did breach the standard of care, there was no harm to the patient. Something else killed the patient. So it's not just that there's a duty. It's not just that we breached that duty or breached the standard of care. That breach has to be the proximate cause of injury to the patient, to the person. So that's what has to be done. It also has to be harm, which I think I kind of covered. So what really happens when there's malpractice? In general, most malpractice, when it does occur, is a result of one of these two things. It's either poor data gathering, we didn't do a good enough job taking the history doing an assessment, we weren't diligent enough in gathering data, or it's poor decision making. We got the data that we needed, we just didn't act on it appropriately. So I just want to finish up this brief section, this brief intro, just a couple of bullet points that I think are very important. And you can read those. I hate to just 3 slides to you, but failure to diagnose on the physician side is the most common cause of malpractice. As paramedics, your job is not to diagnose. On your side, the most common cause for legal action is most likely going to be that you didn't follow your protocol. On the physician side, it's failure to diagnose. Being good at the bedside will help to prevent a lawsuit ever being filed in the first place. And that is really something we stress to everybody who is potentially in harm's way when it comes to malpractice. The family or the patient has to want to sue you. And there's plenty of documentation, there's plenty of research that's been done on this topic in terms of who sues providers, who files malpractice. The ones who felt like they got good service or they made a connection with the provider are much less likely to sue than those who felt like they had a connection, who felt like the provider cared about them. So showing that empathy, trying to make that connection, developing a rapport with the patient, showing that you care and you're not just in a hurry to get see them. Those kind of things matter. Not necessarily when it gets to court, but it can matter in preventing it from getting to court. A couple other facts up there. I wanted to focus just a little bit on the last one. That number can be comforting, reassuring, but that number can also be a little bit misleading. The reason it can be misleading is that a lot of the cases that a lot of the cases that are obvious malpractice just don't go to trial. There's a settlement before trial. So the ones that go to trial are the ones that leave a dispute. It's either not frivolous enough to just get thrown out and the plaintiff just says it's taking worth my time, and it's not obvious enough that there was wrongdoing like cause calling and breach of the standard of care, where the defendant's going to say just write a check and make it go away. Of the ones that go to court, where those factors in dispute, juries tend to side with the defendant. So it's a pretty heavy burden on the plaintiff because juries, now those numbers vary state to state, but that's what's been reported to me from Ohio. Juries tend to want to trust that we as providers, as healthcare professionals, are doing the right thing. It's the plaintiff's job to prove that we didn't. So just a brief intro to malpractice there. I wanted to open up just if there was any questions from you guys, anything that wasn't clear or anything that wasn't covered, just malpractice in general. Haven't yet? Coffee hadn't quite kicked in yet? Okay. But here's our schedule for today. We've actually altered a little bit. We're scheduled to go to 12:30. I think there's a good chance to get done before that, but we're going to try to stick to the schedule pretty rigorously. So, attorneys, I'm going to hold you to your time limits as best I can so we stay on schedule. So, without any further ado, let's get into the case that we're going to be presenting today. So, here's our case. An 83-year-old female initially calls City Fire Department for a lift assist after having slumped against the couch. She has vague feelings of fatigue for the past few days. She's had some weak and dizzy sensations for the period of time. There was no trauma sustained during the fall. On medic's assessment, she's mildly tachycardic, normal tensive, has normal mental status. There's no trauma sustained during the fall, no signs of trauma on the legs. The patient lives alone. She's independent. Paramedics put the patient back on the couch. Patient declines their offer of transport to the hospital, and CFE returns insecure. Here is their run sheet. I'm hoping you can see that pretty well. I can read the comments at the bottom. The 301 City Fire Department, ALSPF, 83-year-old female alone in the living room, seated on the floor, slumped against the couch. Patient states she has been feeling tired for the past 3 days, felt a little weak and dizzy, and slid off the couch onto the ground, remaining involved. Patient denies head injury, loss of consciousness, no neck or back pain. Patient normally walks with a walker, lives alone and independently. Walker is upright next to the couch. Patient requesting CFD lift assist to get her back onto her couch so she can watch TV, no other complaint. The CFD assisted patient back onto couch without incident. Examination of patient's extremities shows no signs of injury. Patient declined transport to the hospital. EMS returned in service at 12 minutes. So what happened next? We wouldn't be here if it was just a normal everyday thing and everything went well, right? 6 hours later, the same crew was called back to the patient's house. Patient is still tachycardic, but now she's hypotensive, confused, and hypoglycemic. There's been no fall or injury. She's in the exact same spot on the couch where they left her 6 hours ago. There's this run sheet. This time, care is much more aggressive. They address her shock. They address her hypoglycemia. Address her altered mental status. Textbook. What it says at the bottom here. This one. Medic 301 of City Fire Department, AOSTF, 83-year-old female lying supine on the couch, moaning, confused, and listless. Patient seen approximately 6 hours ago for lift assist, placed back onto couch by EMS, appears to be in the same position. Brief physical exam reveals no sign of injury. Patient in room smells strongly of urine. Neighbor came to check on the patient, found the patient confused, and called 911. Patient is cool to the touch, confused, hypotensive, tachycardic. Responds to verbal stimuli, oriented to person and place, but not time. Patient vomited ×1 with EMS. Airway was suctioned. Thereafter, patient maintained airway. Patient hypoxic, placed on non-rebreather with good improvement in oxygen saturation. Patient hypotensive and tachycardic. EKG shows sinus tachycardia, no SVT, no stenting. Patient started on 1 liter normal saline IV fluid with gradual improvement of blood pressure and rapid ED. Finger stick blood sugar low at 48. We administered 250 milligrams, 25 grams of IV-B10 with subsequent blood sugar improvement up to 143. Upon review of patient's medication list with the neighbor, it was discovered that patient regularly takes Norco, 4 milligrams intranasal naloxone was administered given altered mental status. No change. EMS departed scene, lights and sirens at 18:14. En route to Akron City ED, blood pressure and heart rate gradually improved with fluid resuscitation. However, patient remains listless and confused. OLMC contacted and advised the situation. OLMC doc recommends patient be seen in room 60 upon arrival to ED. NFO, care transferred to Dr. Gallo in room 60 at 18:24. CFD returning to. Usually the usual and scientific. So the patient is transported to ED, but obviously still critically ill. Diagnosed with septic shock secondary to a UTI. Patient later dies of overwhelming sepsis. The family in Chicago sues the CFD paramedics and UNC basic personally, CFD agency itself, and CFD's medical direction team for the death. So we are about ready to get started. I'm going to turn this over to our attorney here shortly, but first, a couple of things. Some housekeeping issues. We do have a scheduled break. So if you need some more coffee or food, or if you need a bathroom break, we can do that during the break, or if you need it before that, out the doors at the top to the left and to the right, our restrooms from the CEUs, I believe, all the hand with a piece of paper with a QR code to get your CEUs at the end of this. And that's what I got. So first things first, we have some work to do. I need a jury. So we're going to select a jury of 6 from the audience. And we have multiple different fire departments here. So I think it would be good if we were able to get 6 different fire departments represented on the jury. So I'm going to call out fire departments and see if we can get some volunteers. The jury is going to come forward and sit in the second row here, these red seats. We'll ask you to sit in even numbered seats that'll get 6 across the row. Who's here from Akron Fire Department? Would one of you be willing to serve as a jury member for this? On down. There you go. Setting the tone. I like it. How about Barberton? Who's here from Barberton? Someone's here from Barberton. You signed in. There we go. All right. Thank you. How about from North Canton? Who's here from North Canton? Adam, so thank you for that. How about East Lake? You have a representative from East Lake? Even number chairs in that second room. Thank you. How about from Uniontown? Who's here from Uniontown? Can we get a Uniontown representative on the jury? Go. Even number chairs, thank you. And how about Clinton? Yeah, just going to even number chairs, just so we're kind of split out a little bit. Clinton? All right, so we have our 6 jury members. Eventually, when you guys go deliberate, we'll ask you guys to pick a foreman who represents you. But for now, you can just all be the jury members. So I am going to give you guys some brief instructions before we start the trial. And then I'll give you other directions when we're ready to send you to deliberate. Okay, members of the jury. Medical professionals are expected to recognize certain symptoms of illness and injury and are expected to be aware of the associated risk of harm during the course of treatment. They're expected to be aware of the harm that a medical professional of ordinary skill, care, and diligence would foresee under the same or similar circumstances. Medical professionals, however, are not expected to guard against the risk of harm that a medical professional of ordinary skill, care, and diligence would not foresee. In a case such as this, the issue of whether the medical professional has exercised ordinary care requires the plaintiff, who has the burden of proof, to produce the testimony of an expert witness who can establish the recognized standard of care in the medical community under the circumstances, and also establish that the defendants failed to exercise ordinary care. An expert witness is one who, through study or experience or both, has acquired skills that make him or her better qualified than the layman to form an opinion on the subject in question, and whose guidance is necessary for the jury to reach an informed judgment. Such expert opinion is also required in order for you to determine whether any such claim deviation from the appropriate standard of care was a proximate cause of Brenda Collins' injuries. Defendants are also entitled to present expert testimony that they rendered reasonable, appropriate medical care, and that their actions or inactions were not the proximate cause of Brenda Collins' injuries and death. Likewise, defendants are permitted to testify as an expert in their own defense and provide opinion testimony as to why they believe they met the standard of care for their specialty, and or that they were not the proximate cause of Brenda Collins' injuries and death, but they are not required to do so. At this time, we are going to open it up for opening statement from the attorneys, 10 minutes each.
Good morning. My name is Frank Mascott, and I represent the state of Brenda Collins. We're here today for a wrongful death case involving premature and preventable death. Ms. Collins was careless and casual and alternately negligent conduct of the 2 defendants that have sued Brenda Collins. Ms. Collins was a mother of 3, a grandmother of 8. She wasn't in a skilled nursing facility or rehab facility. She lived independently. She did her own grocery shopping. She was active and she volunteered at her church. She called 911 for help on November 3rd, 2021 around noon. She wasn't feeling like her normal self. She was dizzy, confused, and she'd been feeling weak for days. Defendant showed up. They picked her up off the floor and put her on the couch. Took her vitals, which blood pressure and heart rate. She has an elevated heart rate. She was tachycardic. Her blood pressure, the respiration rate rather, is high enough. They ask if she wants to go to the hospital, and she says, no, I think I'm okay, and they leave her there. They don't stand there that can do it well. They don't do more than 1 evaluation of her blood pressure and heart rate. They don't do a blood sugar test. They don't take any KG. They don't ask if they can call her family, and they don't call her. Um, you're not even going to see use of the transport in the records. And they leave her there alone. 7 hours later, a neighbor calls and reports that Miss Collins was essentially lying close to lifeless on the floor. She was hypoxic, tachycardic. She was in the throes of sepsis and dying. 911 comes back. They give her some fluids. She has minimal improvement. Was taken to the ER where she later dies. This is not a complicated case. We wouldn't be here if the defendants had gotten it right. A mother and a grandmother is dead because of their actions. And it's for that reason that at the close of this case, I'm going to ask if you return a verdict. Thank you very much for your time.
Thank you, Counselor. Defense Counsel, opening statement. Alexa, are you able to pull up the first EMS run sheet that was died and so on? Okay.
Right, good morning, everybody. We're here today because unfortunately, Ms. Collins, an elderly woman that lived alone, died unexpectedly, unpredictably, and unpreventably on November 4th of 2021. Her death was not preventable, wasn't predictable, and it most certainly was not the fault of these EMTs that are sitting here in front of us. These EMTs and paramedics went to this woman's home around noon that day because she had slid off her couch, which had happened before. They assessed her, they assisted her, they made sure she was safe, and there was absolutely no reason for them to believe that she was close to having a medical emergency. They offered to take her to the hospital, but she declined, as is her right, since she was fully competent, completely normal mental status, and a Glasgow coma score of 15. What you didn't hear from the plaintiff of these statements, ladies and gentlemen, is that what they have to do is prove this case to you. As the defendants, the EMTs and the paramedics, they don't have to prove anything to you, but they will. They will take that witness stand and they will tell you they took good care of this woman. They absolutely met the standard of care, and there is nothing they should have done, nor anything they could have done that would have prevented her death. Number one, the plaintiffs have to prove to you through an expert. They can't just say it as though it's fact. They have to prove to you through a qualified physician that these two were negligent and that they caused this woman to die. Not that some unknown version of sepsis caused her to die, that they caused her to die. You will listen to their testimony, and it is our belief that you will conclude after you listen to their testimony and objectively look at the medical records that they absolutely met the standard of care. What the judge will tell you at the end of the case, in addition to what he's already told you, is that the way that you evaluate these folks that are sitting here in front of you is prospective. That is, with the information they had at noon on that day. That's how you evaluate their conduct, not knowing what happened 8 hours later, looking back. That's not how the law in Ohio works. That's not how we evaluate care. We will hear from Dr. Gallo, a board-certified emergency medicine physician and director of EMS, who will come in here and tell you these folks absolutely met the standards of care, that this patient had no signs consistent with sepsis when they came and saw her early in the day, that there was no reason to believe she was unsafe or that something horrific was going to happen later that evening, and that there was absolutely no way they could compel her to come to the hospital. What you will see in the medical records is that these EMT Dagger, EMT John Bon Jovi, did in fact meet the standard of care in taking care of this patient. When they got to, and I have to wear glasses with this, another time. When they got to her home, they took a medical history from her. They asked her what medications she was taking. And the history that she was given was that she had hypertension and was taken lisinopril. That's what they knew. And that's the history that was given to them. They are restricted by what they're given by the patient. They did, in fact, take a set of vital signs. Her vital signs were completely normal, but for a very mildly elevated heart rate that they will tell you, as well as Dr. Gallo, can be caused by a multitude of things that do not need to be said. You'll hear from Dr. Gallo. There are many, many different definitions in the United States currently of sepsis. She met 0 of them at noon. She didn't meet the Infectious Diseases Society of America definition. She didn't meet the SOFA definition of somebody to be concerned about sepsis with. She didn't meet the Surviving Sepsis Campaign definition of sepsis. That's because she wasn't septic when they were there, and there was no reason to believe she was headed. When they did come to her house, John Bon Jovi and Mick Jagger not only took her vital signs, which showed that her blood pressure was normal and her pulse ox was normal, as well as the respiratory rate. There's no such thing as a high normal. Normal is normal. She was, importantly, despite describing that she had some periods of dizziness over the past few days, which they will explain to you is common in the elderly, she was entirely alert and oriented time, free to person, place, and time, and her Glasgow Coma scales were 15, completely normal. They discussed how she was feeling with her. She indicated to them that she was feeling well, but needed them to assist her to get back onto her couch, which they did. Out of an abundance of caution, they examined her extremities. There were no signs of trauma on her extremities, on her head, or anywhere else. And they offered to take her to the hospital just to get a further workup if she so chose, which she did not, and is absolutely her right as a woman to be confident to make her own decision. This same crew came back later that evening. Later that evening, they got a more extensive history on this patient because the neighbor who called 911 gave them more extensive history. They had more information, but this was a completely different patient than what they had earlier in the day, and they had no way to predict that this is where we were headed for what they saw that morning. They came back, they took multiple sets of vital signs, they gave her, it got IV access, they gave her IV medications, and they immediately transported her to the hospital. Ask yourself, ladies and gentlemen, if these folks don't know what they're doing, why would they know what to do on that second visit and not do it on the first that they got a week? Doesn't make any sense. These EMTs have decided to devote their life to taking care of people, helping people that are in need, and they did their jobs on this case, and that's the standard of care, which they will tell you, and Dr. Gallo will tell you, they not only met the standard of care, but earlier treatment for this patient with antibiotics or anything else would not have changed the outcome of this patient. With the close of the evidence, I'm going to ask you to return the verdict in favor of the defense, Mick Jagger and John Bon Jovi.
Thank you, counsel. Plaintiff's counsel, you may call your first witness.
Good morning, doctor. Please state your full name for the record.
Rebecca.
And where are you currently? And what position do you? Can you give us a little bit of background on your education or your education history?
Sure. So I graduated with a degree in biology and a minor in biochemistry from Baylor University. I followed that with medical school at each of Northwestern Medical Center. I underwent my university in Florida, and subsequently I specialized in emergency medical services
Are you board certified?
and board certified in both emergency medicine.
Did you have a chance to review some of the records in this case?
Yeah, so I reviewed two EMS run sheets, one noon on November 3rd, 2021 for Wind Pond, and then a subsequent visit April 100. From syndication.
I'm going to give you can you tell me from looking at the patient care report, which I'll mark as exhibit 1, what in third upon?
So according to this run sheet, they observed a woman who was weak, was not living like herself, who hadn't living heart rate. Like we took the criteria actually substance criteria. How to look blood pressure by that. They did not observe a complete set of vital signs. They were missing a temperature, which is information depending on which criteria you're using specifically serves. They did not see fact that it took them off to have this. They also failed to obtain blood sugar. I would argue some training for it. These information have been we claim dizziness, not right, or common on top of this, also reflection.
And as part of the differential, you're not just ruling things in, you're ruling things out, correct?
Correct.
And for example, taking blood sugar might tell you, looking at the blood sugar, the diabetic, this is why she's feeling tired and things that's not improved. There was a comment in the opening when I touched on this woman, her heart rate was 110.
Correct.
That's clinically that is tachycardia, correct?
Correct.
That is in fact one of the two SOFA criteria. Sets, is it not?
It is one of the SIRS criteria. For to SOFA, one of the two criteria present would be the blood pressure of 95 systolic.
Okay. So in fact, she did have criteria set under either statements.
Yes.
As an ER doctor, if you treated a patient with
Estimation.
the patient or the conditions that EMS encountered upon arrival, are all of those consistent with someone experiencing symptoms?
Absolutely. And, I'm more concerned in our service. I would say stuff that the elderly years at all. It can be very difficult to pick up on anything. It can be very, very rare and very very ready to jump on and have technical suspicion, particularly if there's other also understanding that elderly patient may not have the regulation. And it can be solved. And I would argue that this is, especially for a number of persons, it can be very simple.
There was perhaps some insinuation of is it possible for someone to develop an infection, develop sepsis, and then be dead all in the window of maybe 7 hours, or is it something that being taken into?
So the current data we have is coming out in both retrospective and prospective data that is showing us that your mortality, your risk of mortality and death actually increases by the hour. Every hour that you delay antibiotic, and you have certain time frame. Most of those studies were the increasing mortality over 6 hours. Many of them that your risk of mortality can go up by 35% per house that your antibiotics are delayed. And yes, you can certainly use the contraceptives within that time period of 6 hours.
In your opinion, the recently period medical fronting, with Ms. Collins, suffering from sepsis at the time with EMS presented,
That's not.
in your opinion, to a reasonable degree of medical probability, that Ms. Collins was transported to the emergency department for severe antibiotics with resuscitation is precedent with her death and dehydration.
Yes.
If she had been transported to the ER, I mean, what would you do?
So, they've been in emergency department, right? We have certain collective temperature and blood pressures. Medication. Admitted for hospital for social room. Or the, she would have been like, there's some. Which would, be abnormal vital signs plus suspicions. And we would have started her antibiotics, admitted her to the hospital. And all of the more likely than not, would reduce her numbers in her body and the fact that.
Those are all the questions.
Defense counsel, your witness.
How many years you've been practicing as an attending in emergency department?
6 years.
So I'm not sure you've been practicing long enough to call this, but you remember the surviving steps of maybe the analyze 10-15 years.
The initiation of that campaign would have probably been before my time.
You know how the surviving sections came from the original time.
So I'm familiar more with the 2016 update of the QSOFA. Originally, this was SIRS. I believe so that would have been temperature. So in excess of 38 or lower than 36. That involved your white count, about 12 or lower than 3. I was trying, yes, trying to. So the sentence definition of criteria. I'm not sure what you're asking because there's clinical criteria. And there's the definition of sepsis, which is the body's, essentially to paraphrase, if the body's overall response to an overwhelming infection that results in end organ damage. Correct. Which I'm not sure what you're asking.
Are you aware of what the
Yes, which is what I was trying to describe to you before you asked me another question.
know that we don't have a factor?
Correct, because you have one that you are not able to assess because it was not evaluated for, but you do have one criteria present that was evaluated for, which is heart rate. Sure.
That would not fit.
It would be impossible based on that record to say because it failed to obtain a temperature. Correct. Correct.
Current definition of sepsis, which is a known source of infection.
False. I would say that she had signs of organ dysfunction on that first day. Suspected source, yes, I organ dysfunction. I'm not understanding your question here. You do not have a nose versus infection. We're acting in a pre-hospital environment.
Where these other two should have not. Fit the definition of that. You feel what only involves three criteria, right?
Or, so you're supposed to go in the hospital. Does report.
That criteria. Anything to go with that.
Yeah.
And that's because she did not have any documented that taken. Yeah.
True, it's based on their record.
And one of the other items that's considered in the field scoring system is respiratory, right?
Correct.
And in order to meet that criteria, that's rate of 20, right? Her respiratory rate was not.
Respiratory is one.
Answer the question. Her respiratory rate is not greater than 20, right? You'd agree with me that certain elderly patients can have intermittent dizziness, fatigue, tiredness.
Not normally, but it is common.
So it's your testimony on your own that you don't believe that it.
That would not be a usual state of health. No.
So Dr. Gallo testified to that. Right?
Yes.
Correct. You agree with me that high fever and chills can be a sign of sepsis. True.
Yes.
We don't have any indication that this is or Ms. Collins related to the emotions that she had shown.
It's not a predictive now. And no, she won't.
You see if there's the narrative portion of the note where they will take the information up here.
Yeah.
You can write down she told them she had shown, right?
No.
Difficulty breathing. Fine.
Or this is the
Spring pain of the fine.
sure.
And then
As far as I can tell from this record. No, but I think I can only attest to what's in this record because I don't have there. There is no parents coverage.
for blood pressure.
Depends on what you're calling normal. So according to QSOFA, it was not normal. Well, it depends on when, according to the 2016 update, it's normal.
So it's your testimony. That's guidelines. You're not blood pressure, right?
You're talking about the QSOFA, like the 2016 sepsis 3. That's with QSOFA that is less than 100, would meet the criteria.
Right here. Greater than 90.
Greater than 90 does not tick the box for abnormal or SIRS.
Greater than 90. Normal. Right?
For SIRS.
One of the other things that was concerned with that. That. Well, something that. The building site, right? And according to this record, she did not put it, right?
According to this record, no.
Talk about a couple of things that you certainly agree with you that it was within the standard of care for you folks to do a blackout. Correct.
That's part of the not complete. Part of the standard, yeah.
You understand on that end? Right?
And it is within.
And so assessing her mental delusion.
Correct.
Taking vital signs within the standard of care, correct?
They didn't. I would argue that a vital sign is not within the standard of care, no matter which vital sign we're present with that day.
The ones that they took.
The fact that it was incomplete.
So that.
Yes.
Was it within the standard of care for them to offer to take her to the hospital?
It is within the standard of care.
Within the standard of care to ask her about the medical history and to ask her what medical assistance.
Yeah.
And you're aware that then and the EMT back later that day that they took 3 separate blood tests, right?
Correct.
They got further information from the neighbor who was not present during her visit and recently died, correct?
I have to refer. But
You're not sure if she was diabetic or neighbor.
I'm not sure. The fact that
Certainly, if they were made aware that she was diabetic, and it was appropriate for them to get ID access and start E10 by
on the second visit.
certainly everything we did on that second visit, including getting that relevant.
Yes.
And ma'am, you haven't seen any evidence that an autopsy demonstrates certain.
Sure.
What's other person?
Thank you. I'd like to remind both attorneys that we are recorded. So if you are like me and you go for longer, it's okay. Please either speak into the microphone or if you're going to prolong a little bit, you can use the handheld microphone. What's your turn? Plaintiff, can you call your second witness?
Good morning, Chief. Could you please state your full name for the record?
My name is Lee Chapin.
And what is your current appointment?
I'm currently I am the chief, fire chief and the EMS coordinator for the city of Remote Falls Fire Department.
How long have you held it?
I've been serving my community for over 35 years and as chief fire department.
Do you have any sort of certification?
Currently, I am certified through the state. I am a paramedic, an EMS instructor, and I've also maintained my national paramedic. I'm faculty for a number of national and international organizations that promote cardiac care, pediatric care, trauma care, geriatric care as members of faculty. I also serve as a consultant for medical directors in some departments in reviewing the protocols that they're working with.
If you have a chance to look at the records in this case,
Yes, I did.
can you tell me the reason, you know, for the call and button 321 at approximately?
So you-
Sure. Could you tell me the reason for the 911 call at noon? Okay. And what is a witness?
How about that? I think we have the microphone.
See if I place exhibit one for your reference. Can you tell me what EMS personnel, two defendants here, are on the night of the-
So in their documentation, they have listed that on arrival, they found an 83-year-old female alone in her living room. She was seated on the floor. She was slumped against the couch. Patient stated with her that she'd been feeling tired for the past 3 days, felt a little weak in vision, and she slid off her couch. I continue to also acknowledge in the report that the patient was alert and oriented. Apparently, having illness that
She was tachycardia. Right?
in the vital signs we saw, we have 4 listed. Her BP was 95/60, heart rate was 110. Respiratory was 1. Also, yes, she was back.
Can you tell me at that point, is it appropriate to ask the patient if she wants to go to the hospital? And then just
There are some big things that have to happen before that. Yes, you can ask, but I would say the squad would be required to get some more information together before we do that.
right, you need to work up the patient and either rule in certain things or rule out certain. True.
That's true.
You have a duty, an obligation to work up this patient and make sure that they're not suffering from an infection themselves. Some of them life-threatening condition.
Sure.
Can you tell me what sort of things the defendants seated here could and should have done on November?
One of the things to note here is invalid assist. Invalid assist is for an individual, not a patient. Protocol that we're working on, or they're working on, states that if a patient, if an individual goes to a complaint of pain, injury, or illness, then they go from an invalid assist, a lift assist to a patient catalyst. And as a result of that, they are required by their protocol. Please, the patient care support. So yes, they would have to come back to the report. They have done the blood pressure, they have done the pulse, they have done the respirations. The next thing they would do, because the patient is complaining of being tired, weak, dizzy, so they will do a couple, do a respiratory. Blood sugar, just to make sure they're not missing. Even if they don't know the patient is diabetic, it's still to be. The heart rate is tachycardia. Many reasons it can be tachycardia. But her systolic blood pressure is 95, and that is the lower end of normal sensing. So with that heart rate being elevated, we would want to do a check to make sure that it's cardiac or is this really sign shock.
Could they have also split her? CF.
Everything will be good as well as evaluation. We would stand that patient up. But it's important for us as a paramedic and the protocol to show that patient is on the floor to live alone. Why couldn't it be done? But that's it. If we got them up, in this case here, they still they're on the couch. Part of our evaluation, standard of care based on protocol. We would not want to leave. The competent paramedics would not want to leave from that division. If she couldn't get back up again or she fell again.
Based upon your records, should they be in?
No, they did a very cursory vitamin. And based on the documentation that's on the report, I can't tell you if they did anything else. Best patient.
When you ask a patient if they wanted to transport it, can you tell me the process of asking a patient if they want to be transported? What could and in fact should be done as part of the process?
Again, we started with a lift assist and then lift assist. That is an individual that's technically not a patient until they tell us something. Part of our interview, our assessment process. He told us weak, he was tired, he was busy. That by protocol makes sure the patient requires us to do this assessment report. When you do an assessment report and it comes to the point of transporting, we only have two choices. Either treat and transport the patient, or the patient can refuse transport. Patients do. But if they're going to refuse transport, our protocol, the protocol that this department is working under, requires their paramedics, their EMS staff, to get what's called a patient refusal. In order to get a patient refusal, paramedics by protocol are responsible to identify the risks and benefits based on their assessment to inform the patient of those risks and benefits so that the patient can make possibly a better determination of what their health care is.
And let me stop you there. Based upon your review of Exhibit 1 and Station 2, and the only document defendants produced during discovery, did they in fact do that?
No, they did not do that.
Given your more than 35 years of EMS experience, can you tell me to a reasonable degree of medical probability whether the two defendants met or slated in their treatment?
No, they did not. They essentially came into the house, took some cursory vitals, picked the patient back up, put her back in the couch, and left it.
Chief, those are all the questions. Thank you.
Defense counsel, your witness.
So I want to start by confirming with you, you are getting paid for your testimony, correct? Next,
Yes.
And so what you've been asked to do by the folks that are suing this EMT and this paramedic that are sitting in front of you, you're getting paid to come in here and tell this jury that they were never, right?
That is correct.
The Monroe Falls Fire Department where you work, that is in close proximity to city fire department, right?
That is correct.
So to some extent, your business competitive, right?
Not competitive. No.
Squads may take, or your squad may be called versus their squad for the same patients in the same area, right?
No.
All right, so you're completely separate geographic areas and never overlap.
Based on jurisdiction. Yes.
In your role of, getting paid to come in and criticize these folks, you understand the standard by which you are supposed to judge them as a prospective standard, correct?
Yes.
Meaning you don't get to know the outcome and look backwards and put the pieces together from there, right?
Yes.
I heard you just say that all they did was come in, take a set of vital signs, put her back on the couch and leave, right?
Correct.
Let's go through the things they actually did that were within the standard of care in addition to what you just outlined here. So first of all, when they came in, according to the medical record, they spoke to this patient about what her medical history was, and she told them that she had a history of hypertension and was taking lisinopril, correct?
Correct.
And that was certainly appropriate to do, right?
Absolutely.
They also assessed whether or not she was alert and oriented and determined that she was alert and oriented to person, place, and time, right?
Correct.
And that was certainly appropriate to do, correct?
Appropriate. Yes.
You noted in the medical records that they spent at least 27 minutes with her, correct?
That is correct. Yes.
So in that 27 minutes, they did more than just come in, take some vitals and put her back on the couch, right? What else did they do for 27 minutes?
They took 4 vital signs.
So let's go back to the noon visit. In terms of how, what they did at that visit as well, they also did a Glasgow coma scale, correct?
That is correct.
And what a Glasgow coma scale score is what is the mental status of this patient? Are they confused at all? Do they have any pain? Are they reactive to voices around them, etc., correct?
She received a Glasgow coma score of 15. She was absolutely focused.
Right, but before we get to that, I'm asking you what a Glasgow coma score is in general. That is a way to assess a patient's mental status and if they're confused at all, if they're exhibiting signs of pain at all, if they're responding appropriately to stimuli around them, correct?
That is correct. Primarily used for trauma injuries. Yes.
But certainly a useful tool in assessing whether or not a patient's mental status is intact. Right?
Yes.
And in this case, you got the highest score you can get, 15, right? And that was appropriate for them to do as well, correct?
Correct.
It was also appropriate for them to describe that they found her alone in her living room, seated on the floor against the couch, and to get a history from her that she had had some tiredness and dizziness over a few days and that she had slid off the couch onto the ground, correct?
Correct.
It was also appropriate for them to take a look to see if it looked like she had any trauma to her head, neck, or extremities, right?
Correct.
And they noted that they took a look at that and she didn't have any such injuries that were visible, true?
True.
It was appropriate for them to discuss with her the fact that she normally uses a walker and to make sure that that was within her reach by herself, right?
That is correct.
And are you ever the person that's scheduled to go out on runs with your crew currently?
I run every night. Matter of fact, I did this last night.
Certainly you've been on calls where it is a lift assist, correct?
Correct.
And certainly because this was a lift assist, it was appropriate to assist the patient back onto the couch, correct?
After the proper assessment, correct.
And it was also appropriate, I know you talked about this, if for the sake of the question that EMT and paramedic had a discussion with the patient, offered it for benefits of going to the hospital versus staying home, and offered to put them in the hospital to see the fine. That's the right to do, correct?
Absolutely.
Those are all the questions I have, sir. Thank you.
Okay, we're going to call one more witness before we take a break. Defense counsel, you may call your.
Morning, doctor.
Good morning.
Would you introduce yourself to the ladies and gentlemen of the jury, please?
I'm Dr. Doug Gallo. I'm here at the City Hospital. I'm not the director of Summa.
Tell us a little bit about your, starting with college, your education.
Sure. I graduated from Georgia University in biology to school presidency of Memorial, North Carolina, in a scholarship to the director studies in the very years like that. And came here
And being involved in training EMTs, paramedics, and in one of the EMS firms. What do you like?
all the insurance.
So you're the one that assesses whether or not paramedics are meeting the criteria that you want them to get certified as a work actor.
I work with a team. But yes, that's good.
Are you board certified in stuff?
I'm board certified in nursing medicine and it's not a field fellowships.
So just to give the jury a little idea of how this works. Let's go to obviously undergraduate education that you talked about, then medical school. And then you did your residency training.
Yes.
And then you did a fellowship in. Are you licensed?
Yes. Yes.
Doctor, I'm gonna ask you some questions today and call for you to get a treatment. Question and give me those to me. That's the reason to read medical. Okay. How many years have you been in surgery?
Oh,
And in your 12 years serving as an attending in the emergency department, have you had clinical to diagnose and treat sepsis?
yes.
I'm going to ask you some of the big questions first, and we're going to go through into some of the pieces from there. But first of all, did I ask you to review some records in this case and give me an objective opinion about whether or not you're going to take it's dagger or you have a lead that
Yes.
did you arrive at a conclusion after you reviewed the medical records from a long time?
So good.
And what was your opinion of whether or not here? Visit number one at 12:03 p.m.
I feel the standard of care was better than this.
How about visit number two? Did you do standard of care to profitable?
Standard of care was better than well,
And doctor, is it this patient, whether or not it was predictable or preventable that this patient, if we presume that that's accurate, would die from septic shock about 6-7 hours after this new visit?
it is always possible for elderly patients or any patient to be compensated rapidly than expected. Estimate that they have available at the time. It would be extraordinarily for long. Too soon, tell them.
Let's talk about why would we put narrative logically if we knew that that was going to happen at that noon visit. One of the things that can give you some insight into a patient's ability is but
Yes.
and vital signs will tell you about a patient's hemoglobin.
Yes.
But then I'm from back and forth with plaintiff's expert, and I know you weren't here to hear that. But would you agree with me that the blood pressure of 95/60 is
Blood pressure in 95/60 is within my limits.
you agree with me that a respiratory rate of 20 is within the?
Yes.
Would you agree with me that a pulse ox of 97% is within?
Also, yes.
And in terms of evaluating patients for sepsis, if a blood pressure is too low or a respiratory rate too high and a pulse oximetry reading too low, can those be indications of sepsis?
Yes, they can.
And in this case, we had a blood pressure, a respiratory rate, and a pulse oximetry reading that were all within.
Blood pressure, the pulse ox, and the respiratory rate.
So we've heard an awful lot about this pulse, 110. And that somehow one vital sign in a patient means you make a diagnosis for them. First of all, does that make any sense to you as a clinician that one vital sign makes a diagnosis?
We always tell the residents and the medics never to hang their hat on one single data point,
Why is that?
because there are a lot of potential explanations for why a patient can attack heart.
What
Not
are,
always.
oh, sorry, go ahead.
Sorry, it's not always underlying sepsis. It could be anxiety that the ambulance just arrived. It could be pain, it could be fear, it could be dehydration. It could be lots of different possibilities. Just because someone's tachycardic does not necessarily mean they're going to septic shock.
And wouldn't you expect that if a patient was septic and going into septic shock, that they would have more than one abnormal vital sign?
It's common, but not universal.
You'd agree with me that one of the
Sepsis and septic shock.
would you agree with me that if you have 15 and the patient who's alert around time 3, that would not elevate sepsis first criteria in a differential diagnosis in a patient who has a score of 15 and is alert around at time 3?
Having a normal mental status would argue against sepsis and be a negative point on this use of the criteria, which is what our agency says.
And then let's talk about the patient criteria. So we talked about that a little bit with Dr. Johnson and Doug. There's 3 criteria used for the people, correct?
So,
If a patient gets 1 point on that, meaning this patient under Q-SOFA would get 1 point for a solid blood pressure under 1, correct?
yes,
That 1 point that she would get still means that she's in a very low risk category for sepsis, correct?
Yes, we don't use the SIRS criteria in the pre-hospital world because EMS can get a white blood cell count. So you can't tell someone the white blood cell counts is up 12 and less than 4. So we use QCell. We have one criteria in QCell, which is low risk by definition.
And certainly you don't go around giving every patient that is low risk on a Q-filter score antibiotics when you don't know they have an infection, correct?
That would be sure.
And one of the things that you mentioned, Infectious Diseases Society of America, an open statement, but one of the things that they talk about a lot with clinicians like yourself is not overusing antibiotics, correct?
Yes.
And not prescribing antibiotics when you don't have a known source of infection or clear indication that an infection exists.
The infections department is always encouraging us to be judicious with our use of antibiotics to avoid selecting for existing infection.
Um, Dr., based upon the information that EMS had at the time of the call at 12:03 p.m., when they spent 27 minutes with this patient, talking with her and assessing her, taking the totality of the information that they had, is it your opinion that there was absolutely no reason that they should be concerned about sepsis based upon the information that they had at that time looking for?
By the numbers, she doesn't qualify for sepsis based on the information they have at the time. And with the normal medical status, the complete lack of pain, and for lack of other complaints, it would be a significant presumption to the point that I would worry that their deductive processing was because if they immediately assume that every repeat is a person is involved in sepsis.
Was it appropriate for them to talk with her to find out the history of her injury, to make sure that there were no visible signs of injury on her body, and to offer to her to take her to the hospital?
Yes, yes.
By virtue of the fact that they're offering to take her to the hospital, does that mean that in the EMS world that they believe she requires hospital?
Offering to take someone to the hospital or transport someone to the hospital, it's not necessarily that they need to be admitted as an inpatient, but thorough diagnostics that ED that EMS doesn't have access to can be helpful. The majority of patients who present to our emergency department are discharged.
That they get this, they make this woman get up and walk.
If she had no complaints of pain, if she had no signs of injury, and if this was not a traumatic fall, she really slid off the couch and walked with walker at baseline. So as such, she needed help getting vertical again. Once they put her back in the position, she refused further care than they were really not allowed to.
1 minute remaining, Council, please run the first word.
And when they returned on this second visit, was the care that they provided to her appropriate and timely based upon the patient that they found when they came back?
Yes, new data was available that necessitated a different course of action. There was excellent.
Do you think it was predictable or foreseeable that they would come back and this patient would have a blood pressure of 70/20 and a heart rate of 135, a respiratory rate of 30, and a pulse ox of 87%?
Based on the initial data they had during call number 1, no.
Is it your opinion, to a reasonable degree of medical certainty, that the EMT and paramedic in this case met the applicable standard of care?
Yes,
Is it your opinion that earlier administration of antibiotics and supportive treatment would not have prevented her?
in this case, no. So unfortunately, there was no way to see that coming.
Those are all the questions I have.
Plaintiff's counsel, your witness.
Morning, Doctor.
Good morning.
How much are you being paid here today for Pearson's testimony?
Nothing.
You're giving. Okay, fair enough. You're a pro bono expert. I want to touch on a couple of things that Attorney Hess brought up. You said it's never right, and correct me if I'm wrong, never right to hang your hat on a single set of data. Single data.
It's always dangerous to make an assumption and fixate on solely one piece of. You should take it in context with the whole.
Right. It's important to gather as much information as you have when you're on scene in order to rule things in, rule things out, and provide good care to the patient. True.
Within the context of the limitations of what EMS does and doesn't have at their disposal in terms of diagnostic equipment. They have on the X-ray, lab capability, nothing like that. All they have is the limited ability set that they present.
Sure. In the context of what they have, the tools they have, do they have the ability to take an EKG?
They do.
Did they do that at noon on November 3rd?
That was not part of the call.
I don't know what that means. It was not part of the call. Did they do an EKG or did they not?
They did not do an EKG on the first call, on the first run, but there was no indication that they needed to.
You do some teaching for EMS, EMTs, true?
Yes.
In what circumstances do you counsel them with an EKG should be?
Anytime you have a patient who may be suffering from lying ACS, coronary syndrome, cardiac dysrhythmia, syncopal episode, those are our big three type problems where EKG.
Under those big three, it's a shot in the dark. One of the symptoms of tachycardia.
Tachycardia of 110 is a possible indication for EKG, but the majority of dysrhythmias, the like of which we're looking for, atrial fibrillation, attack, flutter, are typically a lot higher, 40, 50, and 60. The majority of heart rates in the 1 to 3s are sinus tachycardia.
What would be the downside?
Other than waste of time and resources, the 30 minutes.
How much time does it need?
About 5 minutes.
How much resources does it take?
Relatively little, but you have to keep in mind the other priorities on scene for the patient. Is that relevant to their call? Is that what she needs? Is that what she requested of the squad?
Let's talk about some of the other capabilities they have on the scene. Do they have the ability to monitor someone's blood glucose?
They do.
Did they do that in this case?
On the first call, no. On the second call, yes.
So you would concede that they do in fact have that ability to improve?
Yes, they do.
What would be the benefit in not testing someone's blood glucose at noon in November?
There is no material downside other than that's not what she was called for. The emergency department, MS as their extent, has the capability to do great many things, not all necessarily.
No material downside. Are you doing a cost benefit analysis?
Patient gets what they require.
How much time does it take to test somebody?
1 to 2 minutes.
Have you ever, in your teaching, advised that you should take more than one vital reading? If you do serial readings to see
There are cases where that is a requirement. We have talked about several times, but that varies based on the complaint that they have and context of the situation before them. Someone stubs their toe, they don't necessarily need multiple sets of vitals. They'll do those immediately.
Did Miss Collins stub her toe on November 3rd, 2020?
She slid approximately 1 foot to the floor.
Other than sliding to the floor, is there any other complaints that she related to 911 call for help?
The report indicated that she was feeling tired. Well,
She'd been feeling tired for days, true.
I don't have any problem.
She was dizzy and she was dizzy, true.
She relayed to them that she was dizzy. That
Oh.
this wasn't the first time it happened.
Do you have a single criticism of the defendant?
In cases like this, it's always easy to judge in retrospect. The most important thing to remember in this case, in my opinion, is what you do with the data you have. During the first call, I see no reason to believe that did anything other than what was necessary with the information that they got. Second case, the vastly different presentation, different vitals, different needs, different mental status, and that's going to necessitate entirely different care pathway and a different future.
I think it was a pretty easy yes or no, but sometimes we all be a single criticism.
Their care was appropriate respective to the two cases.
Are you able to give a yes or no?
Yes.
Do you have any criticism?
No.
Is it important to document the care that you render to a patient?
Very.
Why is that very important?
Because it serves both as explanation of why what was done and wasn't done. So it wasn't done. And it also allows you to inform future colleagues that we are documenting something else, for example, what you saw, why you did what you did. And it can also provide you with the legal protection later on. Hence our discussion.
I'm not sure what that means. Hence our discussion to the
It is the best recollection of what did and didn't happen on the scene 3 years after.
right. So if we were to hear something for the first time today, for example, later today, in defendant, what they did for whatever reason, here nowhere in the record, it's better to trust the records that we have because that is an accurate snapshot of what occurred on that.
Couldn't set it up.
And in fact, you teach that in your class, the EMS, the professional spaces, keep an accurate and comprehensive record. I'm curious, I'm going to hand you the first patient care records from the 12 o'clock call.
Yes.
Sure. In your opinion, does Exhibit 1 do a good job of accurately capturing the cares that was rendered?
I would say so, yes.
Right. So we have to rely on that document to tell us the totality of what occurred on November 3rd.
This is the best documentation that we have available. If there was nothing else produced in Discovery.
Wrapping up, there was a comment about, I think you said it would be extraordinarily rare or illogical to conclude that she would die of sepsis 7 hours. Is that accurate?
It is a significant logical job to assume that after sliding off the couch, that they were going to die of septic shock. Though regrettable, it would be very difficult.
Is your job as an EMS or EMT professional to predict when someone will die?
No, our job is to make decisions and treatment and vendor care based on the information available, based on the information available. In this case, care was executed according to protocol based on the data they had.
Thank you for your time.
You're welcome.
We are ready to resume. Defense, you may call your next witness.
I am firefighter paramedic Mick Jagger.
And tell us where you work currently and what your day-to-day schedule is like.
I currently work at City Fire Department on a 24 hours on, 48 hours off schedule.
And what is the training that you had that led you to be a paramedic where you are currently?
I went through first EMT basics training, then went to firefighter 1 and 2 for a 240-hour course, and then I went on for a 10-month paramedic course.
And so why is it that you decided to want to be a paramedic?
I was first going for computer science in college, and I wasn't really enjoying it all that much. And then me and one of my friends went out, and he got seriously injured and needed to call the fire department to pick him up, and I helped him throughout this entire endeavor. And I finally changed from wanting to do something with computers to wanting to devote myself to medicine.
And has that change that you made and this new career choice that you made been good for you?
Absolutely.
What is it that you enjoy about it?
I enjoy that when people are in their most dire time of need, I'm the one that shows up, and I have the skills capable to assist them.
So we're going to go through the things you did for Ms. Collins, but you've heard what's happened in this courtroom here today, and you've heard Mr. Mazguy accuse you and your counterpart of being careless and not paying attention to this woman's complaints whose house we went to. First of all, is that accurate or not?
Absolutely not.
Do you take every single patient that you take care of seriously?
Yes.
We'll talk about why, but did you meet the standard of care in taking care of Ms. Collins?
Yes.
All right, well, let's talk about what you did for her and how you approach a scene when you go to take care of a patient in the first place. So tell the jury, because probably a lot of them don't know. How is it that you and John Bon Jovi become the people that go out to Ms. Collins' house? How does that work?
Are you talking about how we are dispatched to a house?
Yeah, so once somebody calls 911, what happens next?
So a patient would call 911. It would get sent to a 911 dispatcher, who then relays that call to our fire station to tell us where the call is at and the disposition of the call.
And do you get any information about the patient before you go?
All that we know is the disposition of the call.
And what was the disposition of it?
The disposition was a lift assist.
And tell us when you hear that this is a lift assist, what does that mean to you?
To me, a lift assist is a patient who has either fallen on the ground or is on a uneasy surface and requires 2 or more personnel to assist them with getting back to a location that they find suitable.
Is that something you had done before November 3rd of 2020?
Yes.
Tell us when you get to a patient's home and you know this is an 83-year-old female before you go in.
When I check the run disposition, sometimes we get an age, sometimes we don't. But for this call, we did get an age that this was an 83-year-old.
Tell the jury what.
My very first interaction is introducing myself to the patient, and this achieves 2 things. One, if they respond and are able to answer my questions, it assures me that they have an adequate airway and are also breathing properly. And it also shows me their level of consciousness.
Do you assure that their airway is clear?
Yes. Yes.
And you can feel free, the first page of your run report is up next to you there. You can feel free to look at that if you refresh your memory at all, but when you initially got here, talk to the patient and take care of her or provide her with lift assist. I mean, in your mind, you know you're gonna be providing lift assist, but if there's something else that she needs or you find some problem when you get there, are you going to address it?
Yes.
And was there any unexpected finding once you got there and anything that you believe, looking backwards at your care of this patient, that you should have done that you didn't do?
No.
All right, let's talk about, it looks like from the medical record in the middle there that you talked to the patient about her medical history. You told her that she had a history of hypertension and took placenta, right?
Yes, that was all the information we received from the patient.
And it might sound obvious, but you don't know what you don't know, correct? I mean, you're limited to the information the patient gives, you, right?
I'd say so.
And this is the information that she gave you about her medical history and her meds that she took, correct?
Yes.
We'll talk about that in a minute, but you came back later that evening when a neighbor called again and you were able to elicit more medical history and more meds, correct?
Yes, from the neighbor that came over.
And that was going to be my question. That information, the more information that you got on the second visit, that came from the neighbor, correct?
Correct.
When you took vital signs, first of all, we've heard an awful lot about, some extent, about temperature. In a patient for whom you are going to provide lift assist that's not complaining of fevers, chills, or feeling sick, are you going to necessarily take a temperature?
It is not my first line to assume that anything would be temperature-wise wrong with the patient from a lift assist.
Why then do you get a blood pressure and a pulse, respiratory rate, and pulse oximetry?
A blood pressure, pulse, respirate, and pulse oximetry are good baselines to see from a patient to see their current status.
And was the blood pressure in your training that you got for her 95/60, was that normal?
Yes.
Was her respiratory rate of 20
Yes.
and her pulse ox of 97%, was that normal?
Yes.
In your training, does a heart rate of 110 fit criteria for tachycardia?
I would say it's on the higher side, yes.
And to what did you attribute that tachycardia on the day that you went and saw Ms. Collins?
I would say that the tachycardia probably came from her falling off her couch, as she told us in the report.
And does it happen that when you go to see a patient at times that their heart rate's up because they're anxious from having EMS in their house?
Yes.
Can patients' heart rates go up from pain as well?
Yes.
She did not describe pain to you when you spoke with her, though, correct?
Correct.
In a lift assist, there's no requirement that you do a Glasgow coma score on her, correct?
I do not believe so.
And you went ahead and did one anyway, correct? You or your counterpart, correct?
Correct.
And why did you go ahead and do that if you weren't necessarily required to?
We took a Glasgow coma scale because it takes little to no time and it can give us another piece of information that would be beneficial for us to see if she was having any other altered mental status changes.
And she told you that she had this history of feeling a little weak and dizzy. Did the fact that she had a Glasgow coma score of 15 and that she was alert and oriented times 3 give you some reassurance that her mental status was normal?
Absolutely.
We've heard some criticism that you should have forced this woman to get up and walk. Do you agree with that?
I do not agree that we should have forced this woman to get up and walk right after she just fell off the couch.
Why not?
I believe that if we had her get up and walk, she might have fallen again, which could have led to even more damage to the patient.
When you been taught about, learned about sepsis, in patients in housing,
Correct.
and understand that sepsis is the body's response to an infection, correct?
Correct.
Was there anything in your assessment of this patient around noon on the day that you saw her that led you to conclude that you should be worried about sepsis when you took care of her?
No.
How about the heart rate of 110? Doesn't that by itself, according to the plaintiff, mean she's got sepsis?
No.
Um, is it unusual for you to have an elderly patient with a heart rate of 110?
I wouldn't say unusual given her disposition.
If this patient didn't have any signs of sort of impending doom, for lack of a better phrase, why did you offer to take her to the hospital?
We offer to take everybody to the hospital. It's never a bad idea to go to the hospital, just to get checked out for anything that might pop up later.
And so when she declined transport to the hospital, you certainly had a discussion with her about what they could do for her at the hospital versus staying at home, correct?
Correct. We also stated to her that even if she wanted to go to the hospital later, she would be able to dial 911 again and we would return.
And that's where you're documenting on the second page that the patient declined transport to the hospital, correct?
Correct.
1 minute, counsel, please wrap up the question.
When you came back later that evening, would you agree that this was a completely different patient than you had seen 6 hours earlier?
Yes.
And on that visit, to fast forward here, you did 3 sets of vital signs. You did a 4-liter kg, you got IV access, you did a blood glucose level, and we know you did all of those. Would you have hesitated for a second to do those on the first visit if you thought they were indicated?
No.
You believe that you and your EMT basic, John Bon Jovi, that were with you that day met the standard of care in your care and treatment in this college?
Yes.
Right, those are all the questions I have. Thank you.
Counselor, plaintiff's counsel, it's your witness.
Morning.
Good morning.
It takes little to no time and gives us another piece of information. I think I heard that in your testimony here today. Would you agree that an EKG would take little to no time and give you another piece of information?
I believe it would give us another piece of information, but it does take more time than a Glasgow coma scale.
How much time does an EKG?
To reference to an earlier statement, about 5 minutes.
What about have you ever performed an EKG?
I have.
And how long does it take in yours?
About 5 minutes.
How many times have you administered it?
Probably more times than I can count.
Have you ever taken a patient's vitals, seen that they were tachycardic clinically, and then decided to do an EKG or administer an?
I believe just based on a tachycardic presentation does not dictate that an EKG needs to be performed.
I'm not asking you whether it dictates that it needs to be reported. I'm asking you in your own personal experience, have you ever taken someone's heart rate, seen that it was elevated, and then decided to conduct an EKG so that you had a little more information?
I have not done an EKG based solely upon a heart rate.
Okay. Have you ever taken someone's glucose?
I have.
And in fact, you did on the second visit, did you not?
I did.
Okay. Do you recall the results of that blood glucose reading?
On the second visit,
Well, I guess let's back up a little bit. Did you take it on the first visit?
it was not taken on the first visit.
Okay, why not?
She did not have a presentation that would state that she would need a blood glucose level to be taken.
What presentation would be consistent with low?
Altered mental status is the biggest one that comes to mind.
What about feeling tired or weak?
weakness and tiredness can lead to a blood glucose level to be taken, but with her Glasgow coma scale and her level of consciousness, I believe that one did not need to be
Okay,
taken.
what about dizzy?
Stating back to the Glasgow coma scale and the level of consciousness, I believe one did not need to be taken.
Did you ask the patient to dive in the first?
I asked her for her medical presentation and the medication that she was taking, and the medical history that we obtained is on the care report.
Is that how you talk to a patient? Give me your medical history. You ask her if she's diabetic? Or-
I asked her for any pertinent medical history that she can give to us, and the only thing that she was able to give to us was hypertension.
Is that the phraseology that you use? Give me your pertinent medical history.
I wouldn't say it exactly as curt as I'm saying it right now, but
How did you say it in this particular case?
I stated to her that, ma'am, is there any sort of medical presentations or any past medical history that we should be alerted about at this time?
Um, if in fact her blood glucose levels were low at the time of your first presentation, which we don't, true?
What was the question one more time?
Sure. Do we know for a fact that her blood glucose, what her blood glucose levels were at the time of both call?
No.
Is it at least a possibility that you would acknowledge that in fact she had low blood sugar and wasn't thinking clearly and could not consent, for example, to a beef treatment? Is that at least a possibility?
Are you saying there's a possibility that she could have had a low blood glucose level?
Sure.
There's a possibility for that, and there's also a possibility for it being within normal levels.
Well, we don't.
We do not know either side.
And why don't we?
A blood glucose level is not taken for the patient with a normal mental status.
When a patient refuses transport, is there any sort of documentation that they're supposed to fill out?
Usually a run refusal form should be filled out.
You mean usually, and should there are protocols that you have where you do in fact have to fill out that?
When a patient calls 911 and states that for a lift assist or for any type of call, if they would like to go to the hospital, or if they don't want to go to the hospital, but the paramedics on the ambulance or the EMTs on the ambulance think that they should go to the hospital and they refuse transport, then a refusal report should be signed.
Okay, where is the refusal report on this case? I didn't see it.
I do not see a refusal report in this record.
You know why that is?
I don't believe one was taken.
And why not?
From the clinical presentation that I see right here, and from her chief complaint being just a lift assist, and from our findings, our personnel on the ambulance believe that she should not have gone to the hospital with the current amount of information that we have.
I'm not really sure that was responsible. Per your protocol, were you required or should you have filled out a patient review?
I believe since the patient refused and per our protocol, I believe that a refusal form should have been filled out.
Okay, so you would concede you didn't do it.
I would state that a run refusal report was not filled.
Given that you're here testifying today under oath, are there any other concessions that you would make to the jury of things that you could have done? The 12 o'clock call, the 12 o'clock moment that you did not.
No,
You believe you did everything true?
I believe so.
There was a question about should you have asked the patient to stand up, walk a couple of steps, and you said we had to get her up and fall to lead to more damage. Are you testimony?
I believe so.
Assuming by damage you mean harm, because a human nowadays.
Yeah.
True.
True.
Okay. How many times has a patient fallen and caused more damage to themselves when you're administering the
I believe not every single patient falls after doing a walk test, but there have been an occasion to where a patient has been told to walk by themselves and have fallen back down.
I'm not sure if that would respond. Have you ever administered a walk test? Ever asked them to walk a couple steps and test their condition?
Yes,
Someone ever fallen and you asked them to do that?
yes.
How many times has it happened?
I would say not often, but I don't have a number off the top.
Because we believe that sit here today under oath, that's a serious risk, that you would rather not conduct the test because we believe it's such a great risk. That your testimony?
I
You
believe
didn't do them.
I would rather not cause harm to a patient if I were able to.
Are there any other sort of tests or evaluations that you could have done that you didn't do because you were worried that it would cause more damage?
No.
So then what is your reasoning for not conducting the other? That being blood glucose, EKG, anything else?
The reason we did not do the blood glucose is because she was within a normal mental status for a patient of her age. Or it could be a normal mental status for a patient of her age. The reason we did not do a 4-lead EKG was because that we did not believe that she had any underlying cardiac dysrhythmia problems or the otherwise.
Any other reason?
I believe that is it.
Did you call her family? I don't know the grandma's problem years of age, busy, didn't get that, but anything like that.
We did not.
And why not?
We went to the house to perform a lithosis, which we then did. And we tried to administer additional help, which we did. And then we left the scene as we are taught to do.
Did you even offer to call the family?
Not at the current time.
I know.
We didn't believe that calling the family at the current time would change her disposition.
Have you ever before offered to call some family or in fact called their family, let them know their loved one being evaluated and seen by you?
I believe the priority of a call is the patient and not the patient's family.
I heard that's response. Have you ever before in your years of experience called someone's family, let them know their loved one is being evaluated? Didn't get anything.
Usually the patient calls their own family.
Have you called someone's family in your years of experience?
No,
How long have you been here?
I've been an EMT for about a year.
A year. Incident was in November of 2021, so you weren't even licensed at the time. Is that right?
I've been a paramedic for about 4 years.
You were fresh out of the academy at 1 year, right?
Counselor, please wrap up your question.
Those are all the questions I have for you today. Thank you very much.
Counsel may call the next witness.
Morning. Good morning. Can you tell the ladies and gentlemen of the jury your name and occupation and employer?
My name is Jonna Bon Jovi, John for short. Occupation is EMT basic at City Fire Department.
And what is the training and education you had that led you to your current?
I've done about 4 months of EMT school to get my EMT basic card
And how long have you been working for City Fire Department?
for about 4 years.
And have you worked with Mick Jagger before the day that we're here to talk about?
Yes, I have a couple of times.
And You two work well together and feel like you take good care of patients when you're together?
Absolutely.
Um, what is the difference between what the two of you do? So you're the EMT basic and you're the paramedic. Do you have a different role or are there different things that each of you can do?
So paramedics can do a lot more than EMT basics. So EMT basics can only give certain medications. We primarily give oxygen and cardiac medications such as nitroglycerin, but we like help administer it if the patient has it already. Just certain things that we can do, like paramedics can start IVs, can get fluids, they can do all that restore, and just pretty much assist.
And even with things that you are not certified to do, if you think a patient might benefit from something or need something, you wouldn't hesitate to tell the paramedic that's with you that you think that might be a good idea, right?
Right.
So if you thought this patient needed a blood glucose level or an EKG at that first visit, would you tell him that?
Absolutely.
Can we conclude by virtue of the fact that it wasn't done, that you both did not believe it was indicated?
Right.
And let's talk about why that is and a couple of other items. First of all, when you go into a house together and you're the EMT basic and with a paramedic, how does it look? Do you go in and do certain things while he does others, or is it different every time?
So pretty much, I will go in and get a set of vitals, and my partner would get a further assessment, assess her any underlying injuries, what's going on for today, and then help with the call.
We heard this retrospective claim that, oh, well, maybe she had a fever that day, you know, she complained of fever and you're chilled. And since you were the one that took the vital signs, would it be fair to say that when you're putting a cuff on somebody's arm for blood pressure, checking their heart rate and checking their pulse oximetry, that you would be able to feel if they felt warm to you?
Correct.
And if they felt warm to you, would you go ahead and take the temperature?
Yes.
Why didn't you take the temperature in this?
Her temperature didn't seem to feel abnormal of any sort to me when I was taking the heart rate and the vital signs.
And when you spoke with her, did she say, you know, I've been freezing cold, I have the chills, I think I had a fever, anything like that?
No.
If she did say that to you, would you have taken her temperature?
Absolutely.
If she had complained of any kind of chest pain or feeling like her heart was racing or anything that you thought might be cardiac related, would you have discussed with Mick Jagger here that maybe an EKG?
Yes.
Was there any reason based upon the information that you two got on at 12:03 on November 3rd, was there any indication of doing an EKG on this?
No.
Was the blood pressure that you got for this patient within normal?
It was.
Was the was the pulse ox and the respiratory rate within?
Yes.
Did you believe at the time you took care of her that her heart rate was higher than normal?
It was slightly elevated.
Because we know that when you guys came back the second time around, her heart rate was significantly, right?
Right.
With a heart rate of 110, what in your training are some of the reasons her heart rate can be 110?
Her heart rate could be 110 just based off of like anxiety, stress, maybe just from the movement that she's been doing. Like I know in older patients, a lot of not even just a lot of movement, just like regular movement, walking across the room can elevate her heart rate. It's just that exertion on the body that can do that.
And we know that on the second visit, when you guys came back, this patient had multiple abnormal vital signs and mental status, correct?
Correct.
And at that time, you and Mick Jagger got IV access. You gave her, or the collective, you gave her D10, IV fluids, got a blood glucose level, and did an EKG, correct?
Correct.
Is there any reason that you would not have done those things at noon if you thought they were needed.
No,
Is your priority to take good care of the patients that you take care of?
yes,
And would you hesitate to do a test because it might take some time or because it might cost the patient money if you thought it was needed or in that patient's best interest?
no,
Are there any tests that you think you should have done or things that you think you should have done that weren't done looking back at this?
no. We performed the tests that we needed to perform based off of the information that we given at the time.
You were given a history, and I want to clear this up. When you came to her house, she gave you a history of feeling dizzy. Not I'm dizzy right now, correct?
Correct.
So one of the reasons that you do the Black Coma scale score and the assessment of whether or not the patient is working oriented is to make sure he's not having mental status changes, like, correct?
Correct.
Um, and in terms of, let's see, in terms of this form, I think we got a little mixed up in what the protocol is here. What I heard Mick Jagger say in his answer to the question, it was if you think the patient needs hospitalization, meaning I think it's unsafe to stay home, that, and you tell the patient they should go to the hospital, that then you have to fill out this form, correct?
Correct.
Like an AMA form against medical advice, right?
Yes.
In this instance, though, at 12:03, you did not believe this patient required hospitalization, correct?
Correct.
Therefore, did anybody have to fill out any form, even though you offered her admission to the hospital?
No.
Do you believe, ma'am, that the two of you met the standard of care in your care and treatment of this patient on November 3rd at both visits?
In both visits, we did.
All right, thank you. Those are all the questions I have.
Thank you, plaintiff counsel, your witness.
Good morning.
How long have you been practicing as a
For about 4 years.
4 years? So at the time of the incident, back in 2020, when you had 1 year, it's true.
Sure.
So when the two of you combined, if I understand the testimony correctly, you guys had 2 total years of experience, correct?
Correct.
Going back to the first call, is there any reason, let me back up a little bit. Why did you suggest that any additional evaluations or tests be performed on Ms. Collins to Mr. Jagger that were in fact
No.
you agree that if the full workup of this patient involved taking the blood pressure, heart rate, that's it?
Blood pressure, heart rate, respiration, and SpO2.
Have you ever done a walk test before?
I have.
And in what circumstances have you done it?
When someone has fallen, we want to make sure that they're able to walk and be able to get around the house that they're living in. If someone else is there, then we'll just make sure that they are aware that they know that this patient can get around smoothly, and if not, there will be a continuation.
Why did you not do it?
She seemed competent, and she slid off the couch, so it made it seem like she made it to the couch. She was able to walk to the couch. It just seemed like she was able to get in.
Is it your testimony that you only do a walk test to evaluate someone's physical ability to walk, i.e. there's not a bone sticking out of their leg, and that you never do it, for example, to test their heart rate, they're getting enough oxygen, that sort of thing?
Yes.
Have you ever administered a blood glucose test?
Yes.
How long does that?
Takes about 1 to 2 minutes.
That's a pretty simple procedure, right?
Yes.
And in fact, you guys ended up doing it on the second visit, right?
Correct.
And what were the results?
The blood glucose came back at 48.
When you're taking a patient's medical history, what do you ask the patient?
We asked them, do you have any pertinent medical history that we need to be aware of at this time?
You ever ask the patient to have their ID?
We don't state it like that, but we do ask, do you have any medical history that would pertain to what's going on?
What sort of symptoms can be indicative of low blood?
Low blood glucose would contain like ultra status, flushed skin, cold, pale, clammy, weakness.
Weakness, yes.
Yeah.
Which Miss Collins had, true.
Yes, but that is indicative with people of her age group.
People that are living independently are generally weak. Is what you're definitely.
No, I'm just saying people of her age group, like people in that elderly bracket, they tend to get weak very quickly than the average person.
You don't dispute that her presentation November 3rd was out of form, right?
And the first call, no,
That's a no.
no.
She lived independently. She could go to the grocery store. She could walk, albeit with a walker. True.
True.
And when you found her, she couldn't even lift herself up onto the couch. She isn't standing. It's 2 feet off of the ground. That's how weak she was. True.
True.
And she called you guys for help. Right.
Right.
We put her back on the couch. You put a cup on her, and then you left. Right.
We did an assessment and then she refused transfer to baby.
Looking back, is there anything about your November 3rd, 12 o'clock call, your residential changed?
No,
Um, when did you learn that Ms. Collins had died?
after she was already at the hospital a couple days later.
How did that make you feel?
Made me feel sad because I never want anybody to die, even at an age of hers. It's always a poor change for someone to die. It's always a weight on someone's heart.
You would agree that her death was unexpected and untimely, true?
True.
Any feelings of regret when you learned about her death?
I don't regret any treatment that we delivered for the call.
You guys believe that you did a good job accurately capturing the care that you rendered to patients in the patient care reports that you filled out.
I do.
Those are all the questions I have for you today.
This concludes our witness testimony. The defense attorney and plaintiff's attorney now have 10 minutes each for their closing statements. Plaintiff's attorney, plaintiff's counsel, you're up first.
Ladies and gentlemen of the jury, thank you very much for your time here today. You heard a lot today about what happened on November 3rd. I think the evidence is clear that these two defendants that are seated here in front of me, barely 2 years of experience between them, did a less than okay, and in my opinion, egregious job of working up this patient. This patient was busy, weak, laying on the floor. She couldn't pull herself up onto the couch. She was so weak. She was previously an independent woman. She was a grandmother with children and grandchildren. And she called for help and she didn't get it. They showed up. They put her on the couch. They didn't even ask her to stand up. In Mr. Jagger's words, to avoid damaging her, I guess, risk damaging her. They didn't ask her if she was diabetic, notwithstanding that she was presenting with symptoms indicative of low blood sugar and or sepsis. They didn't take an EKG, but notwithstanding the fact that she was clinically tachycardic, which the defense expert conceded. They did not call her family to let them know that grandma has fallen when there's been an incident. They didn't offer to do that. They did not call her number. They did not ask for qualifications. They did less than the bare minimum. And unfortunately, as Dr. Johnston told you, as a result of that, them not transporting her to the hospital, making sure that she got antibiotics, fluid resuscitation, vasopressors in a timely manner, she passed away. Chief talked a lot about things that we need to do as EMS, CMPs, and paramedics when we evaluate a patient. And he was in agreement that what they did on that day at noon fell well below the standard of care. They didn't sufficiently look her. They didn't do the tests that take literally 1 to 2 minutes to do. We saw her again, took 4 vitals and then left her. And they didn't even fill out a refusal of transport form, which now there seems to be some disagreement between the 2 defendants as to when or when it's not required. And it's for all those reasons that I ask you to return a verdict in favor of my client for $3 million for the negligent conduct of these 2 defendants. Thank you very much for your time.
Thank you, Counselor. Defense Counsel, your closing statement, please.
The reason that we're here in this courtroom and summons jurors and come into this courtroom when we have a judge is because we're here to get to the truth, right? That's what this process is supposed to be. It's supposed to be a search for the truth. And what the truth is in this case, and what we've heard in this courtroom is that although the passing of Ms. Collins is certainly tragic and was unexpected, it is absolutely not the fault of these 2 EMTs and paramedics. They did their job. They took care of this woman appropriately. And there's absolutely no reason to believe that they could know what was about to happen, nor that they should have done something differently that could have prevented it. It simply was not predictable, was not preventable based upon the way that she presented when they came to her house. I stood up here in opening statement and told you that the plaintiffs have to prove this case too. We could have called no witnesses and sat here and done nothing, and they have to prove to you to a probability that these 2 were negligent and caused this woman's death. They have failed completely at that. They have to prove that to you through a qualified expert. This entire case for them rests on Dr. Johnston's testimony. It doesn't matter what the lawyer says, it doesn't matter what I say. What we say is just argument. You have to listen to that testimony as it comes through that witness stand. And what they have to prove to you is that these 2 were negligent. And what we heard was a Monday morning quarterbacking of care that was provided, trying to put the pieces of sepsis back together in care that was appropriate when it was given prospectively to this patient. They went for a lift assist and went beyond what they were required to do even so, took vital signs, did a GCS, made sure she was alert and oriented ×3, offered to take her to the hospital. She declined, which is her right, and she had absolutely no indication that she was going to go into septic shock if she did later that day, because we don't have an autopsy that confirms that. That's their burden to prove that she died of septic shock, and they have not done that either. They have to prove to you that something different would have changed this woman's outcome. And I haven't heard how filling out an AMA form, doing an EKG, taking a temperature, nobody has told you how those specific things would have changed this woman's outcome. And that's their burden that they failed to meet. What we did here and what the judge will instruct you on in the law that he gives you again is that you alone sitting in this jury box are the judges of the credibility of the witnesses, right? So doesn't matter what I think, doesn't matter what Mr. Masguy thinks. All that matters is how you evaluated those folks sitting on the witness stand. And whether they have 10 years or 20 years or 1 year of experience, you can tell that these 2 individuals care about the patients they take care of. They cared about Ms. Collins, and we know they're willing to do the things that they need to do to take care of a patient that they're claiming should have been done earlier in the day because they did them later in the day. There is no reason, and we've heard no testimony as to why they wouldn't do that earlier in the day if they thought it was indicated or if it was indicated by the standard of care. In Ohio, ladies and gentlemen, the plaintiffs are required to prove that they were negligent. They breached the standard of care. They have proved that they breached nothing. We have a Monday morning quarterback expert in here trying to suggest who's getting paid, trying to suggest that somebody should have done something differently because they believe they know the end result before the care happened. Ladies and gentlemen, when you're on an EMS run, you don't have a crystal ball with you. You don't know what's going to happen down the road. You do the best that you can do with what you have, and you provide reasonable care within the standard of care, which is exactly what they did. They got to her house and they talked to the patient, got a history from her, got her medications that she takes. They did a physical examination in terms of making sure the patient didn't have any outward signs of injury. They confirmed that her mental status was normal. They confirmed her Glasgow Coma Scale score was normal. And even though they were satisfied that she was safe, and even though of all these different scoring systems and sepsis definitions that we went through with all of these experts, she met absolutely no definition of sepsis, let alone septic shock. There was no reason for these folks to do more than they did. Out of an abundance of caution, they offered to take her to the hospital. She chose not to go, and that's absolutely her right. Nobody wants their loved ones to die. Certainly not the EMS folks that went to take care of her twice in one day. Certainly not the people that took care of her in the ED, and certainly not her family. But unfortunately, her death, while tragic, was unpredictable and not preventable and not foreseeable. We have brought you testimony from both EMTs and from a nationally renowned EMS physician who's also an ED physician, who told you that everything that these folks did was absolutely appropriate, prospectively looking forward at what the information was that they had on that day. And further, when we know that this patient is suddenly with abnormal vital signs and decompensating in septic shock 6 hours later, antibiotics sooner would not have made a difference. The evidence that you've heard, ladies and gentlemen, through all of the witnesses, from the witness stand and from the evidence that you'll see back in the jury room, which is these medical records that we have from the 2 runs on the 3rd, is that Mick Jagger and John Bon Jovi absolutely met the standard of care in their care and treatment in this college, and they did not cause her death. It's tragic, but we will ask you to return a verdict for the defense because they absolutely took good care of this case. Thank you.
Thank you, counsel. I have some further instructions for the jury before I ask you to retire and deliberate. Paramedic has a duty to act within the standard of care. Standard of care is to do those things that a reasonably careful paramedic or EMT basic with similar training would do under similar circumstances, and to refrain from doing those things that a reasonably careful paramedic with similar training would not do under similar circumstances. The required standard of care is the same throughout the United States. If you find by the greater weight of evidence that defendants fail to meet the standard of care, then you must find that they were negligent. Although some other paramedic might have taken actions different from those used by a defendant, this circumstance will not by itself prove that defendants were negligent. You shall decide whether the actions taken and not taken by the defendant are in accordance with the required standard of care, not what is perceived to be best practice or excellence. Customary or routine practice may be considered by you, along with all of the other facts and circumstances in hand. Although a particular practice may be customary, usual, or routine, this circumstance will not by itself prove the practice to be within the standard of care. You shall decide whether the practices, actions, and lack of action used by the defendant were in accordance with the required standard of care. The fact that defendant's actions did not fulfill the plaintiff's expectation, it does not by itself prove that the defendants were negligent. Paramedic does not guarantee that a treatment or procedure will be successful. Rather, the paramedic's duty is to exercise that degree of care, skill, and diligence, which is ordinarily employed by other paramedics who perform similar treatment. In determining whether defendants were negligent, you should consider their judgment in light of all attendant circumstances and the dates and times of the alleged negligent. The test of the existence of negligence is not hindsight, but foresight, considering all the known facts at that time. Negligence and proximate cause are separate and distinct issues. Plaintiff must prove that the defendant's negligence proximately caused or contributed to cause Brenda Collins' injuries and deaths. If you find that the defendants were negligent, you must also decide whether such negligence proximately caused Brenda Collins' injuries and deaths. Proximate cause is an act or failure to act that in a natural and continuous sequence directly produced the injury, and without which it would not have occurred. Ladies and gentlemen of the jury, do you have any questions before I ask you to retire your delivery? I'll ask that you go to the top of the stairs where the bailiff will be elected to your quarters. I ask that you please, I see the bell. What do you think of that? I will ask that you please try to come to a decision within 15 minutes. In the interest of time. Yeah, actually, so if you mind taking the exhibit with you, you can review them if needed. Okay. Once the jury has retired to deliberate, I'm going to open up a discussion and then people that are left in the courtroom. Okay, so we are going to have some time for more questions once the jury comes back in. Right now, I would like to focus our questions on the defendants and the experts in regards to their experience. We'll have some questions for the attorneys when the jury comes back. What questions do you have from the audience? Please raise your hand if you have a question, and I'll bring you the microphone. Because again, we are recording this, and we will be able to hear what you're saying in the recording. What questions do you have for the defendants or for the expert witnesses? Anybody? No? Well, I have some. So if you think of any, just please raise your. I would ask, let's start with defendants Jagger and Bon Jovi. For someone in your position, this was not a comfortable position to be put in. Talk a little bit about what it was like having care, even though it wasn't really your care. You were playing the role like this was your care. Having your care dissected by a bunch of attorneys and then taking the stand to have to defend it with one friendly attorney and one not so friendly attorney.
It was definitely a different experience, just having to explain why you did what you did and pretty much double down as to why you would do it again, because you know what you're doing. This is an presumably everyday call for you, so you know what the care that you gave to this patient was appropriate for what you found at the time.
I believe having this run report in front of you and thinking that it's like good enough to be defended in court, and then having the attorney just completely rip it apart and then have you explain yourself to it is extremely nerve-wracking.
Anybody from the audience?
In retrospect, whether the jury comes back for or against you, if you had it to do over, would you do it differently? And if so, what would you do different?
If I had to do, you're talking about the first or the second run? Okay, because the second run was great. The first run, if I had to do it differently, probably fix the spelling mistakes in the narrative and get a I would get a signed signed patient declination, even though the the patient in our eyes didn't really need to, from the information that we had, didn't need to go to the hospital. And then a BGL. I don't know if I would get the 4 lead seeing with the history that we have, but I would absolutely be getting a BGL with this patient.
Want to hear a little bit from the plaintiff side. Dr. Johnston, I know this is not a situation that you've been in previously, if I recall from our prior discussions. Offline, I had a couple of conversations with Dr. Johnston beforehand. I can tell you that she was, let's say, not necessarily looking forward to the experience. How did this compare with your expectations, and what was the stress level as you were being approached by a relatively aggressive cross examination?
So first of all, you're terrifying. But that is exactly what I expected. And I think I probably feel like I got grilled harder than anybody. I don't know, but what you need to expect if this ever happens to you is for them to they'll attack your expertise. The first thing she asked me was how many years I'd been in practice. To be honest with you, I didn't even remember, and I just threw out 6. It's actually shorter than that, so I kind of got off easy. But and then guidelines. Like, I knew she was going to ask me about guidelines. I had those guidelines memorized. I had like the 2016 versus the 21 update like ready to go, because they're gonna, and this will be true for what you're expected to know as a paramedic. They're going to ask you very specific things and try and lay you down, and I guess you have to, do the best you can with some of these answers. I don't know if anything that I said in any of those responses would have been like in a real courtroom. I object. You can't answer it that way. I have no idea, but no, it's tough, and it's going to be even worse if this is. I mean, that was tough for me in a fake case where I didn't even care, right? And so imagine being in the hot seat as a paramedic in a case where something did go bad. This was really very real. They will go after that kind of thing, your expertise, your knowledge, your experience, that kind of thing. So you want I think the bottom line is you want your medical record to be as strong and supportive of you as you can. And so in general, that means more data points. It means, being very specific in the things that you counseled the patient on, for example, and documenting that. The patient, something that we, on our side, we didn't really get to was the capacity sides of things. Did she have the capacity to make an informed? Did we even engage in informed consent with her? I would argue no. But you just said she refused, right? And so I think if we'd attacked that more, that would have been even more glaring. And so you don't want to depend on the lawyers to kind of make or break the case for you. You want your case to be solid from what you provided on scene at the time. And typically the more you document and you do for somebody, and the more you document the discussions you have with them, the more that will speak for itself, and you can rely on that.
I think this one's working, Mike. Maybe up. No, it's good. Thanks, Dr. Johnson. As someone who's been involved with one of these before, I can tell you 2 things. First, that if you ever end up in a situation, you should hope that you have an attorney defending you who is as talented and as hardworking and as effective in front of a crowd as Aaron was. That was quite impressive. And the other thing I'll tell you is that this, again, we said this early on, this was very compressed. we jammed a trial into 3 hours. Before you ever get to trial, there will be depositions that are every bit as nerve-wracking and every bit as important. My deposition was 7 hours, and that's excluding the breaks and the lunch breaks. There was 7 hours of questioning that I sat almost exclusively in front of the plaintiff's attorney. So as nerve-wracking as this was for 10 minutes of cross-examination, imagine expanding that into 7 hours. So you definitely want that chart to be locked tight. You'll be prepared well by your attorney, but you want to mentally prepare yourself for what's ahead of you if you ever end up in this situation.
I just have a question for the two defendants. I know who everybody else is, but who are you really? I mean, are you medically trained? What is your role in this?
My name is Joshua Grabowski. I am in the Summa paramedic program here. We started January 3rd, so we're about 4 months in. Not on a fire department yet, trying to get on anything. And we're only 4 months in through our program at the moment. So we were approached about this during a lab session, was like, hey, do you want to participate in a mock trial and get yelled at by lawyers? And I'm like, that sounds interesting. So I signed up.
My name is Naima Green. Like he said, been in the paramedic program for about 4 months. Right now, I work for a private ambulance company, Physicians Ambulance. I'm trying to get fire department. So just working to get towards that. And opportunities came up, so I just didn't let it pass me by.
Just testing to make sure this microphone's working again.
So as a fellow medical director, I just want to know if Doug Gallo was really reviewing this chart, if you would actually have the same opinion.
I'll save my teaching points for after the jury comes back, because I want to make sure that everybody hears it and we only record it once. Not a chance in hell.
Someone else back here had their hand up.
You guys are saying you would not have accepted that. If you were answering the phone call and that's the information you give. What more would you?
I would, if I was taking an online medical call for that, I'd ask to know, number one, is she still tachycardic? Number two, can she handle it on her own, however she normally does that? And number three, does she understand what she's asking for? Is this an informed consent? Or is just I feel like I'm fine. I don't need to go. Does she understand what? And we'll get into that in the teaching points in a few minutes. Patients have the right to make stupid decisions. Patients legally can refuse to be trauma teams with, gunshot to the face, and go to, a freestanding ED with them if they so desire. It's a bad decision. It might set them up to go to a place that literally can't take care of them, but legally, unless they're asking us to take them to Kansas or something, we have to honor that. I think if she had that capacity and she could demonstrate that on the phone on a recorded line, yeah, you're obligated to allow it. I would have been a little more thorough before I let her do it.
Just to give you a little bit of an idea of my background, I'm an emergency doc. I'm a former EMS medical director for a small-ish rural fire department outside of Columbus, and I also do a lot of academic work around documentation. I think the answer to whether this was appropriate is I don't know, and the reason that I don't know is because it wasn't documented well enough for me to know. So based on what we're seeing in the record, I can't really tell you. But the fact that it's not documented that she had decision-making capacity, that she understood the risks of not going to the hospital, what went into our assessment that she had decision-making capacity, that she could refuse, that she does not have sepsis or other life-threatening conditions. Because it's not documented in that note, we don't really have a whole lot to stand on. And we're going to have to go on the recollection of the people on the stand 3-4 years later, 3-4 years after the fact, which is not going to be as clear. That chart is what you're going to have to stand on. You want that chart to have as much information as you can, because your memories will fade. Recollections of what happened will fade. The chart will not. So that is really the most important thing from a medical legal perspective, is to document what happened, to document what the thought process was, so you don't have to rely on memories that are 3-4 years old, where you've seen hundreds, not thousands of patients in between. And the fact that it's not documented, I just don't know if she had decision-making capacity. I don't know if this was an appropriate refusal or not.
I guess my question is gonna be more towards the attorneys and lawyers. How important, I guess I'm gonna apply here, but how important is your memory or documentation of what the scene looks like? How important is that to you all?
I don't want to undermine anything anybody's saying, but I could find something wrong with any documentation. I mean, nothing is perfect. So, documentation is important for sure. It makes, more than anything, my job easier than helping anyone else. But certainly when I prepare people for their deposition and that kind of thing, if you have memory, you are certainly able to speak to it. And there's also the element of what your custom and your routine are, and what you know you always do, and what you know you do as a matter of routine. But that is harder to explain to a jury, that you did those things but didn't write them down. So writing it down is always better. But there's always going to be a time that something doesn't make its way in there. And I'm not suggesting that's good, but it happens, and we do find ways to explain it. But writing it down makes it easier.
Yeah, I think the record itself gives you, is able to fill in anything that you might have in your memory for gaps. So again, more is better. If you rendered that care, you should need to make sure that you actually accurately captured that in your record.
Okay, the jury is back in. I'm not going to ask for your verdict yet. While you were deliberating, the audience and me were asking questions mostly of the defendants and the expert witnesses. I wanted to allow you to come back in when we started to question the attorneys. The last question, which you walked in the middle of the answer, was actually directed at the attorneys. So I would ask if there's questions from the other questions from the audience for the attorney.
All right, so I guess my question for the attorneys is, do you have a lot of experience with these kind of medical cases? Like, how many years you've been dealing with this specific field of the law? And if you guys had anything that you would have done different in this case, as you personally, want you to bring up, or that you would have wanted to touch on?
So for myself personally, I've been doing this about 25 years. And I only represent healthcare providers. So it runs the gamut of whether it's an EMT or a physician or a nurse or a PA or what have you. That's all I do for the last 25 years. So, I was talking to Dr. Gallo about this beforehand, and I know for some of you guys, this record probably seems inadequate in some ways, but in my world, this is pretty good. So, there's always a way to make it better. There's always a way to document more, do more. But the one thing that I do think is reality with this is it's not look like a patient's going to die of septic shock and things like that. So sepsis is a big ticket item right now for juries all over the country. For whatever reason, it's become a very common lawsuit topic. So to the extent that you can do another set of vital signs, if one of them's abnormal, all the better. And I guess a blood glucose level, but I don't think you have the capacity on a run to do like a lactate level and stuff like that, right? So yeah, to do another set of vitals, I think is a good thing. More documentation is always better, but this is somewhere in the middle, I'd say. Well, usually.
Frank, how about you in your experience? And maybe you can specifically address how often, I'm sure that it's more common to have physicians and nurses involved, but how common is it for you to see paramedics involved?
I've been practicing for 6 years, strictly on the defense side. So I was a little out of my element today, and I might have played up the big bad plaintiff's attorney a little too much. In terms of this particular case, I don't have any cases, or I haven't done any cases with paramedics or EMTs, but I do have a sepsis case in a skilled nursing facility with a pressure sore that became infected. So just to kind of jump on Aaron's point, yes, these are cases that are being filed, kind of recognizing these potential signs of sepsis or septic shock. But I would concur with everything else that Aaron said.
Other questions from the audience for the attorneys? Aaron, I noticed when you were questioning the plaintiff's witnesses, I was kind of interested in your choice of words. I think you repeatedly, if I recorded it right when I wrote it down here and typed it in, you asked about several specific things. Was it within the standard of care to obtain vital signs? Was it within the standard of care to get a heart rate? And I thought that choice of words was interesting. I wonder if you can maybe go into what made you specifically, because I'm sure that you chose those specific words for a reason. And I guess maybe as a follow-up, how would you have approached it if the answer from the witness would have been something along the line of, yes, it's within the standard of care, but does not meet the standard of care because it was incomplete?
Kind of using within, same as meet, but I do that because usually when we have a plaintiff expert on the witness stand, they sit up there and talk about how horrible the care is for an hour. So I like to at least talk about all the things they did correctly, since they don't talk about that on their direct examinations. But I like to at least try to pick out pieces of it to show that a lot of it was within the standard of care. But I'm kind of using within the standard of care and meeting the standard of care as the same phraseology, but I don't want it to be that suggesting that that's all you have to do. I guess that's maybe why I'm going to work with it.
I got questions all day, but I want you guys to ask the questions. Anything else from out here? No. I think I have one for you. Let's see if I can find it here. Okay. I forget which witness it was, but somebody made the comment about comment on the time and resources it takes to perform AVC. And I was wondering if you were kind of perked up a little bit when you heard that. It seemed like you kind of tried to pounce on that a little bit. What was your approach to that when the time and resources came up? And did you think, from the prosecutor side, was that something you were hoping they would say because that was your opportunity to come?
One of my favorite questions is always to witnesses, why or why not? Witnesses will start to talk and then kind of grasp for an explanation for things. Maybe they weren't prepared for that question. And then they'll give you an answer that puts them in a little bit of trouble. Why did you perform a blood glucose test? Why not? Time and monetary resources. Oh, how much time does that take? Well, then it kind of sounds ridiculous. And then not only do you get to criticizing, I guess, the care at that point, but then as the juror or anyone watching, kind of thinking, is this guy credible, or is he just making this up as it goes? So that was one where I got a favorable answer that, yeah, I pounced on it.
So I know when I was training for this, and again, if you're ever in a situation, you're going to spend hours many hours with your attorney before you ever get to the deposition, let alone the trial. Being prepped, being told what to say, what not to say, how to respond to this question, how not to respond to that type of question, what to expect from the opposing attorney. So you will have a lot more preparation than these poor souls got in front of you to have, okay? But one thing that I was told when we approach with a question like that is that it doesn't matter. The question isn't whether, how much time and resources it would take. The question is, was it within the standard? Was it the standard of care to perform A, B, or C? If it was the standard of care, it doesn't matter how much money it costs or how much time it would take. It's supposed to be done because it's the standard of care. If it wasn't, it doesn't matter how cheap or how easy or how fast it is. If it's not the standard of care to perform that test, that intervention, that evaluation, then it doesn't matter. It could be free. It could take no time. It's not the standard because I could tell you a million things that are free and take only seconds that you wouldn't do in this or any other scenarios. Right? It's free to do an NIH stroke scale. Did you do it in someone who is called for an ankle sprain? Of course not. It's not the standard. And so the key is what I was trained about, as a potential witness, is that it's just focus on the standard of care. Focus on the standard of care. I met the standard of care because this is what it is. Other questions? Here we go.
Docs, when you're reviewing your reports and stuff, how many temperatures do you actually see? Because when I started, we never took them. Up until COVID, we never had a thermometer on the truck.
Microphone done. It should be on.
We see it relatively rarely. A lot of those, the gun type IR thermometers that you shoot someone's forehead, they all suck. Because you take somebody outside in cold weather and their skin gets cold and makes everyone look hypothermic. Hypothermia over the temperature below 36 Celsius is one of the SIRS criteria for sepsis. So, okay, now we have a heart rate of 110, and we just declared her to be hypothermic. Okay, now we've decided she has sepsis and we have to start down that whole pathway. You get them when your clinical suspicion indicates that you need them. If somebody has an ankle sprain, you don't need a temperature. If somebody has vague, weak, and dizzy, if somebody has nausea, vomiting, or somebody's got difficulty breathing, then yeah, a temperature would be a good idea because that could be potentially infectious. But your average trauma, for example, unless they've been exposed to the elements for hours, you probably don't need them. And like Dr. Palachi said, you don't necessarily want to talk about the cost benefit analysis of surgery, but we do everything for everybody all over the time, the system won't break. So the majority of the calls do not have temperatures on them, but that doesn't mean that you get them when they need.
Okay, so it's time. We're going to hold off on the jury for a minute because first we're going to let the audience decide. So Alexa, if you can pull up the screen. Everyone get your cell phones out. Not out already. All right, so there's a series of questions we're going to ask you here. Okay? So paramedic number one is going to be Mick Jagger. So where you're going to send this is to 22333. Did Mick Jagger meet the standard of care in his treatment of Mrs. Collins? If you think the answer is yes, he met the standard of care, then you're going to text 148787 to that number. I think the answer is no. I'm going to text 149200 to that. You should use that type of number. And I would ask that the jury not vote in this since you already have a vote in the pretty close here, aren't we? Anybody still entering a response, or is everybody responses? Okay, a very, very close. Oh, look at that. Are you kidding me? Do we have a hung jury in our mock trial? That's a defense for, okay, so the audience has gone 50-50, which is a verdict for the defense. that the standard of care was met in this case, okay? Next question. This question will only be for the people that voted no. If he did not meet the standard of care, was Mick Jagger due for the standard of care the proximate cause of harm to Mrs. Collins? So I'd ask that only the people that voted no respond to this question. Okay, so people that voted no seem to be saying the standard of care was not met, but it was not the proximate cause of harm. This one has been pretty lively. So whether disagreements for whether the standard of care was met, there seems to be not consensus, but pretty broad agreement that that was not the proximate cause of harm. Okay, next question, please. Alexa. Based on your answers to these two, and this would be for everybody in the audience, how would you rule regarding the famous thing? So after an anxious moment at the beginning, like the audience has you back and said that this is going to rule in your favor. Okay, Alexa, next. Same questions now for John Bon Jovi. You're not allowed to answer based on which of their music you prefer. Did John Bon Jovi meet the standard of care of Hercules Collins? Or Miss, oh, I'm sorry. There's no code? There's not a code. All right, Paul, everywhere, let me down here somehow. All right, I'm actually gonna have to do a show. Actually, Alexa, if you go to that particular question, then you can go, how can people respond and make sure it says text message? Go to how can people respond? Text message. I'm gonna blame the website, but in actuality, it's the guy who set up the website. Let's just do it by show of hands. Out of the audience, who will answer this question? Yes. Did John Bon Jovi meet the standard of care? Who will say yes? Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Who would say no? 1, 2, 3, 4, 5, 6, 7, I believe that's still good. Okay, so John Bon Jovi met the standard of care for the audience poll. For those of you that voted no, those, I believe, 7 or 8 hands saw in the air. Was that breach of the standard of care the proximate cause of harm to Mrs. Collins? Who would say yes? Oh, you have code. You didn't actually vote. Please, again, people that said the standard of care is not met. Alexa, I think we can get the next one. I mean, we rule the government plaintiff's claim against John Bon Jovi. For the record, I would have been for the plaintiff just because that SOB tried to move my bills out of Buffalo. I would have been excluded. I think the defense would have had excluded me. Alexa, next. Will your practice change based on the information presented today? And And if what you heard today just confirms your practice and the answer to this is no, that's just fine. And the jury can actually answer this one as well. The members of the jury, this question and the next one we ask for you guys to answer as well. A good portion of the audience is pretty confident that they were doing a lot of this stuff right already. That's good. Still about a third of the audience said they would change their practice. Yeah. Okay, Alexa, last one. This one is free text. Not identified. Tell us how your practice will change if you type that up. Anybody? Looks like some people. This is important feedback for us, but I think it's also good for members of the audience to see some insights from some of these things, into what you learned and how you might apply it. While we're waiting for these responses, I'll ask the members of the jury, have you elected a foreman? Someone who's gonna, okay, who is that? Okay. All right. Well, in the interest of time, while people are still typing, I will ask you, Mr. Foreman. That's. I'll ask you, Mr. Foreman, how do you rule in the court or I think this is one of the fact is coming before me. So what is the jury's finding regarding paramedic Mick Jagger? That's the standard of care met. Actually, they wouldn't ask the jury these individual questions, right? They would just say they would. Okay. So the standard of care was met. Am I understanding correctly, Mr. Foreman? Okay. Then. Okay. What is the jury's ruling regarding John Bon Jovi? Was the standard of care met? So the jury has found that the standard of care was met by both paramedics, ruling in favor of the defense. Okay. Before we break, I know Dr. Gallo had a few points that he wanted to make, some teaching things for the evening to make sure that everything that I can here. I will tell you one thing that I wanted to emphasize was that as members of the jury and really as audience members with a paramedic background as opposed to a medical school and residency background, some of this information presented may have seemed a little technical and kind of out of your comfort zone in terms of QSOFA, surviving sepsis campaign, and all these different criteria, and may have seemed kind of confusing. And that's realistic, because if this case was going to a jury, it wouldn't be 6 paramedics sitting there. It would be lay people probably with no medical doctor. And so that is something that is realistic. Now, in the hearing, in an actual trial, the attorneys and the experts would have had more time to try to educate the jury and give you a better understanding of that. But at the same time, they're going to contradict each other. So it's still going to be confusing. It may actually be more confusing after this went on for a few hours as opposed to a few minutes. So that is something that's important to remember, that we say that it's the jury of their peers, but it's always been one of my complaints as a physician with the
with the medical malpractice system. If there's a jury of my peers, it would really be a jury of physicians who have the benefit of the training and the experience working in this field and dealing with these situations from the physician side. And that's not really what it is. The example that I give in reverse is that, yeah, I'm a doctor. I went to school for a long time, but I know nothing about fixing cars. My father did that like to get away from it. If I went out there, my father was working in the car, he'd throw me out, give me back. He actually told me one time, I come out here to get away from you. So I know nothing about fixing cars. I can't even change my own oil. And if I was on some mechanical malpractice case because someone screwed up rebuilding the transmission, I would be asked to make a judgment on someone who does this for a living. And I wouldn't really feel like I was in a position to do that, but that's really my duty as jury member. So these things are, we're going to have to try to get the jury up to speed on a lot of this technical medical stuff over the course of a few hours, or really over the course of the trial that lasts a week. But at the end of the day, you're not going to have the level of expertise of the extra witnesses, of the defendants, of even of the attorneys. So you just got to do the best you can with the information that you got and try and sort out what's in the problem. With that, Doug, I'll turn it over to you. I know a few points you want to make. You want to come up to the podium or use the handheld, whatever works better.
Hello. There we go. Okay, cool. Alrighty. So first of all, thank you everybody for coming out. For those of y'all watching on the Summa online trading portal in about a week, thanks for watching. How do I say the last name properly? Nazca. Right. And Tess, thanks so much. I mean, thanks for volunteering your time. Since thanks for attendance. Thanks for playing our game. Chief Jake, Dr. Johnson, much appreciated. Jury members, thanks for playing along with us, because this case was not real but designed to be plausible, all too possible. How many of y'all have ever been in a case where, oh, it's just a lift assist, it's going to be nothing, we'll put it back on the couch, we'll be gone in 5 minutes and be done. But this was designed to be the tip of the iceberg. So I'm not here to talk about whether or not the standard of care was met. I'm here to talk about whether the actual medical care was consistent with the education we've given you and the protocols and such that we use. And the answer is no. This was garbage. This is a elderly patient who is generally weak and dizzy and just slid off the couch and nothing could possibly go wrong. And that assumption is the first place where we made a mistake here. The points I wrote them down to avoid a rant, because y'all have been here for 3 hours and it's time to go. But as you saw today, documentation can save or damn you. And on average, as Dr. Plotch pointed out, it takes 17 months. You're not going to remember.
That's the average.
Yeah, you're not going to remember geriatric fall over 27B in 17 months. So the chart, as we've said over and over, make the chart your friend. And also, there was a little bit, and Dr. Johnson raised this point too, when it comes to the process of direct and cross-examination, truth can become kind of relative based on how you workshop your case, how you explain things, how you smooth your words. But do not rely on lawyers, even good lawyers, to get you out of trouble. Oh, I can just get up there and say whatever, and they can, use their Jedi mind tricks to make the jury believe that everything's fine, so I don't have to worry about having a thoroughly documented chart. That is not true. We've had cases where the chart is, in retrospect, devastating or non-existent. Do not trust that you can get up there and just sort of double down on your position and that will automatically get you out of the jam. Additionally, in this case in particular, y'all have heard me use the phrase, it's kind of silly, but if tacky, go backy. And you can thank Dr. Murkowski for that one. But basically, that was it's shorthand for if you have an elderly patient in particular who don't typically mount a tachycardia, especially if you're on beta blockers or something like that, you got to be a little bit more worried. Your screaming febrile 2-year-old is going to be 180, no problem. A elderly patient who's 85 years old on metoprolol should shouldn't be sitting still with a heart rate of 110. Something is wrong. That is the tip of the iceberg, and they missed that. And that's part of that was the initial tip off that there was something more dangerous going on here. Lift assist patient should be ended. I used to know the statistics off the top of my head, but it's somewhere in the neighborhood of like 14% get admitted within the next week, or no, 50% get admitted within the next week, and like 5 or 6% die. Don't quote me on that, but a lot of times seemingly simple stuff, benign stuff is just benign. Sometimes there's more dangerous stuff lurking beneath the surface. So by all means, if you are so totally fine, you're asking us to leave you alone. If everything is so great, walk to me, show me, prove it to me. Here's your walker. Let's see you get around. And in this case, had they done that, and in theory, she would have collapsed to the floor again because she's orthostatic hypotensive because she's in sepsis. If she's as good as she says she is, surely she will have no problem walking around the room. We hit this already. Make sure you document medical capacity, not just patient refused and rebolted. There have been successful lawsuits against EMS, stating that their refusal form was insufficient proof. They had had a conversation with the patient about the risks that they were refusing. But there was nothing in there about them documenting medical capacity, and they explained risks. And you might have a heart attack here. This might be an underlying medical illness, and you're elected to go home anyway. Is that cool? Yes, you said yes, and then you left. That is not a golden ticket to get you out of any situation. Just because they refuse does not protect you. Even if they had had an RME form that they could waive in the plaintiff attorney's face, it doesn't necessarily exonerate. And last but not least, beware anchor bias. This got dispatched as a lift assist. How many of y'all have gone, halfway to the house, you're like, oh man, it's 3 a.m, another one, because that's when it happens. They don't call you for a lift. This happened at like 12 noon. They don't call you for the lift assist or for the weak and dizzy person at the nursing home who's had 5 days of nausea and vomiting and then got agitated because they were getting delirium and they got Valium. Woke them up for 16 hours. They were unconscious from giving Valium to an octogenarian. They don't call you at 12 noon for that. They call you at 3 a.m. for that. And you're thinking, oh, okay, just another one of these. And you're already minimizing your head before you even get there. And it biases you. That anchor bias can cloud your judgment. So make sure to keep your eyes and ears open and stop you from making mistakes.
Awesome. Thanks, Dr. Gallo. I'm going to pass the mic over to Dr. Johnston.
Hey, does anyone want to go through this process ever? Cool. So you're going to err on the side of caution and document well, right? And does anyone actually want a bad thing to happen to a patient? No. So you're going to err on the side of caution. You're going to educate them. And that's why we do those things, not because a jury of solid, a wall-to-wall paramedics erred on the side of paramedics, right? Like, I don't want the message that you take away from this to be like, I don't have to change anything because the verdicts today would have been in my favor. Doesn't matter. Do you want to go through that stress? And do you want to look back and go, oh my gosh, maybe if I had transported that patient, they would have been okay. So take the lessons of caution from this. And remember that we're here for patients. And like in this fake scenario, there's still someone that died, right? And we don't want that to happen. So if nothing else, think about the patient. And if nothing else, this is a very stressful, long, drawn-out process in real life.
I would say that if you ever are in a situation that it's possible to answer questions in a way that defend your care while still showing empathy and regret for the outcome, even if it's not attributing the outcome to the actions. It's something like, when Frank was repeatedly asking the defendants, could you identify anything that you did wrong? And an answer along the lines of, I feel like everything that we did met the standard of care. I feel awful about the outcome. I wish there was something I could have done to stop it. But I've reviewed this case over and over again in my head, and I can't think of anything I would have done that would change the outcome. I wish that wasn't the case, but there's nothing I could have done to change it. Something along those lines that shows, yes, you care about the patient. Chief, attorneys, any closing comments? From our defendants / victims for the day. All right.
Thanks for everybody for your time. I hope this was worthwhile for you. Please make sure that you give us good feedback on the surveys and get your CEUs. Hopefully we'll do this again. Thank you.